Okay, so the seronegative spondyloarthritis. Okay, these are the arthritis and they are without the rheumatoid factor. Okay, which generally seen in the rheumatoid arthritis. So they have the similar presentation just like the rheumatoid arthritis. Okay, but they have negative rheumatoid factor, which means no anti-IgG antibodies, and these anti-IgG antibodies are of IgM types, right? Okay, so they are associated with the HLA-B27 and HLA-B, A, B, C. These are of MHC class 1 serotypes. Okay, so all the individuals who are actually B27, they have a very high risk of getting these disorders, right? Very important. All of the disorders, just like the rheumatoid arthritis, they will present you with a prolonged morning stiffness in the hands. Okay, and this stiffness will improve after the exercise. Patient will have a peripheral arthritis, just like the rheumatoid arthritis, of course, right? And along with that, they also have this enthesitis, okay, which is the inflammation at the insertion site of the tendons, where the tendons inserted at the bone. Okay, the patient will have the joint. They will have the pain there also. So they have the joint pain as well as the this tendon pain at the site of insertion. And the most common location is the Achilles tendon. So you will be having a pain at the heels. Okay, so the patient will complain generally the pain at the heels because of that, right? Patient will also have the dactylitis, that means the sausage fingers. And if you guys remember, dactylitis can also be seen in other disorders. If anyone remember from the hemonc.
Polycythemia.
Yeah, polycythemia 1. Good. Any other disorder?
Sickle cell.
Exactly, sickle cell anemia. Sickle cell anemia and the polycythemia, these are the disorders in which you can get the dactylitis also. And because these are the inflammatory condition and the inflammation is systemic, so other part of the bodies can also be involved, like the eyes. Patient can get the uveitis, which is the inflammation of the uvea, right? So all these symptoms are very much common in all these disorders. Okay, they have a categories. First one is the psoriatic arthritis, which is seen in the patients with the psoriasis. Okay, it is a very late complication of the psoriasis. Generally, affects the digits. Okay, and mostly the distal interphalangeal joints. If you guys remember from the previous lecture, that in case of rheumatoid arthritis, patient will be having a proximal interphalangeal joint pain, right? It would be the inflammation of the PIP, but in case of the psoriatic arthritis, patient will be having a inflammation of the DIP, right? So a patient with a prolonged morning stiffness that improves with the use, okay, and the stiffness is in the distal interphalangeal joint. That means they're talking about the psoriatic arthritis. Please do not confuse it with the rheumatoid arthritis. At this rheumatoid arthritis will only present in the PIP and the MCP, right? It won't affect the DIP. Okay. Along with the psoriatic arthritis, you will also have these nail lesions, which are the pitting over the nails, as well as the yellowish discoloration of the nail. Patient will have a yellowish discoloration as well as the pitting of the nails. Okay. Patient can also have the eye involvement, just like any other this spondyloarthritis. Okay. And if it becomes very much severe, patient can also develop a disorder, which is the arthritis mutilans, in which you're having a very this joint damage as well as the skin damage you will get. You can search the images on the Google about this arthritis mutilans, and you will get an idea of what this condition is, right? It is a very late complication of the psoriatic arthritis. Patient can get a pencil cup deformity on the X-ray, as you can see. This is a pencil cup deformity. This is a pencil-like shape of the this finger, right? And it is like and this is forming the cup, right? So a pencil cup deformity you will see on the X-ray. So involvement of the distal interphalangeal joint, and on the X-ray what you will get is the pencil cup deformity. That means that they are talking about the psoriatic arthritis. Very important. Okay, and they can be symmetric or can be symmetric, which means this condition could be unilateral as well as the bilateral. Okay. Second one is the ankylosing spondylitis, okay, in which you're having a symmetric involvement of the spine, okay, and the sacroiliac joint. So this is a condition in which you're having an inflammation of the spine as well as the sacroiliac joint, where the sacrum combines with the ilium, where the sacrum joins the ilium. So you're having an inflammation there, a bilateral inflammation, right, as well as the involvements of spine, right? In this condition, you're having a spontaneous, the simultaneous degradation or the resorption of the bone, as well as the formation of the bone. But the real issue is that this bone resorption is occurring at the center of the spine, right, at the center of the spine, and the bone formation is actually occurring at the periphery of the spine. So at the periphery, you are having this bone formation, and as a result, what you will get is the bridging syndesmophytes, okay, in which you're having a joining of all these spines. Okay, all these spines will join each other, and as a result, it will make the vertebrae immobile, right? So what you will get is the sacroiliac fusion as well as the bridging syndesmophytes on the X-ray. Okay, the erosion occurs at the vertebral bodies, which means at the center, but the ossification happens at the periosteum, which means at the periphery, and as a result, you will get the bridging syndesmophytes, right? So a simultaneous erosion as well as the bone formation occurs in case of this this ankylosing spondylitis, versus in case of rheumatoid arthritis, you're only having a destruction but not the bone formation, right? If you guys remember the last lecture, we have discussed about this pannus formation, and this pannus destroy the cartilage as well as the bone, right? So you are having just the resorption of the bone and the cartilage but not the formation, right? So this is a very huge difference between the ankylosing spondylitis and the rheumatoid arthritis. Okay, so how does a patient will present to? Of course, the signs and symptoms of the systemic inflammation will be there, like the fever, fatigue. Along with that, patient will have a joint pain in the back. Okay, severe back pain would be there. Okay, and the back of the patient will be kind of very much immobile type. Okay, they cannot move them very much. Okay, and along with that, the patient can also have the uveitis and the aortic regurgitation. Okay, and of course, they will have this. Uh, the morning stiffness, which will improve after the use. Okay, bamboo spine you will get because of the vertebral fusion, and we have discussed how you can get this because of the ossification at the periphery and resorption at the center. Okay, and because it is an inflammatory condition, it can also involve the lungs. Okay, and it can cause the restrictive lung disease. Okay, as the disease progress, at a very initial stage, only the lower spines were involved, but as the disease progress, the these upper spines can also get involved. Okay, and at the cost of vertebral junction, okay, when this disease reaches at a thoracic level, right, these costovertebral junctions can also be involved, and as a result, what you will get is the immobilization of the thoracic cage. Okay, and this can also promote the restrictive lung disease. Okay, so in order to test the severity of this disease, okay, in order to monitor the degree of this disease, you can check the degree of the chest wall expansion. Okay, a reduced degree of the chest wall expansion will tell you how much the severe disease is. Okay, if the disease is involving the thoracic spines, right, in that case they will have the immobilization of the thoracic cage, and what you will get is the reduced chest wall expansion. Okay, so a very important thing to consider. And please note all of these conditions, okay, they involves the interleukin 17 and the TNF alpha, just like the rheumatoid arthritis. They also involve the interleukin 17 and the TNF alpha. And the cells that are involved in this condition, these are the Th17 cells. Okay, please note that fact. If someone can ask you this, what cells are causing all these seronegative spondyloarthritis? It was the Th17 cell. Okay, so a, a, a patient with a chronic lower back pain, okay, with a morning stiffness that improves with the use. Okay, on the X-ray, you will be having this fusion of the bones. Okay, decreased chest wall expansion. Okay, and the systemic signs and symptoms of the inflammation. Other than that, the uveitis, okay, enthesitis, joint pain, tendon pain, and all these things will contribute for diagnosis in the ankylosing spondylitis. Okay, and please note you can get a severe lower back pain in case of this multiple myeloma also, right? But please note the age of the patient. In case of the in case of ankylosing spondylitis, it will be a young patient. Okay, and no young patient can have this chronic lower back pain problems. So whenever you encounter a patient who is very young, like 20s or 30s, and they're having this chronic lower back pain, that means something is can be a very problematic, right? It could be the ankylosing spondylitis. And if you get an old age patient who is having a chronic lower back pain, you will always think about the multiple myeloma first. Okay. So a patient with a back pain and they cannot bend, that means, you will always keep this in your mind. You will always think that the patient is too young to be having any back problem. Okay, that means they can have the ankylosing spondylitis. Any doubt on that part?
Is it mediated by TH1 or TH17? Because you have written TH1.
Yeah, exactly. Of course, the TH17 cells will be activated by the TH1 only, right?
Yeah.
So first the TH1 cells get activated, they will activate the TH17 cells, and ultimately it was the TH17 cells which are causing all these problems. Okay.
Okay, got it. Thank you.
Yeah. So please note the HLA-B27 are very important. You can forget all other HLAs, doesn't matter, but this actually you must remember. Stefan asked it many times. Okay. And you can encounter many questions on this HLA-B27 also regarding these arthritis. Okay. So you need to remember that. Now, if you guys remember the GI section, we have discussed the inflammatory bowel diseases. They can also cause the arthritis. Okay, and these are the seronegative spondyloarthritis. Okay, you can get this with the Crohn's disease as well as the ulcerative colitis. Then comes the reactive arthritis, and it is generally seen after some infections. Okay, and the infections of Shigella, Yersinia, Chlamydia, Campylobacter, Salmonella. Okay, whenever you have any of these infections, as a complication of this infection, when the infections get over, you can get the reactive arthritis. So it would be a patient who is having any STD, a patient who is having a bloody diarrhea or maybe a watery diarrhea. Okay, and when the diarrheal symptoms are over, then the patient started having this conjunctivitis, okay, a urethritis, okay, which is also a symptom of UTI, okay, and uh, and this arthritis also, right? A patient who is having a history of diarrhea or any STD, okay, and after these symptoms are over, the patient now having the conjunctivitis, urethritis, and the arthritis, you will always think about the reactive arthritis, right? Very important. And yeah, other histories, a urinary giant swelling would be there, pain while walking would be there, history of diarrhea would be there, UTI would be there, 2 to 3 weeks prior to the symptoms. Okay, very important. Apart from that, patient can also have something known as the keratoderma blanorhexigum, okay, which is a disorder in which you're having a hyperkeratotic vessels. Okay, hyperkeratosis means you will be having a very hyperproliferation of the keratinocytes, right? And they will be forming the vesicles over your palms and the soles. If you guys remember the microbiology lectures, we have discussed, the lesions on the palms and soles can be present in 2 or 3 infections only, right? And does anyone remember the name of these infections?
Coxsackie A, syphilis, and the Rocky Mountain.
Yeah, exactly. Apart from that, as a complication of other infections, you can also get the vesicular kind of rash on the palms and soles in case of keratoderma blanorhexicum, which is a symptom of the reactive arthritis. Okay, so vesicles on the palms and sole, along with the urethritis, diarrhea, history, and conjunctivitis, arthritis, will always think about the reactive arthritis, right? And the patient must be having a history of UTI or this the bloody diarrhea. Okay, very important. Any doubt on reactive arthritis?
No, thank you.
And please note, only the individuals who are having this HLA-B27 in their genome, they can have this condition only. No other these individuals can have that. Okay, very much important. And you need to remember the difference between the tenosynovitis and the enthesitis. Okay, tenosynovitis is basically an inflammation of the tendon sheet, the sheet which is surrounding your tendon, right? And the enthesitis is basically the inflammation at the site where the tendon is basically joining the bone, right? And these enthesitis are found in this spondyloarthritis, but the tenosynovitis are found in the this rheumatoid arthritis. Okay, these are also a very huge difference between the seronegative spondyloarthritis and the rheumatoid arthritis. Please remember that also. Okay. Related to these conditions, you can also have the spinal stenosis, okay, which is a kind of radiculopathy in which you're having a compression of a nerve exiting your spines, right? And as a result, you will get a very shooting pain, okay, which start in the back and and travels all the way down to your legs, okay. So it is because of the abnormal narrowing of the this spinal canals, right? And the compression of the nerve roots occur, and as a result the neurologic symptoms which are correspond to the radiculopathy will occur. Patient will get a shooting pain involving a dermatomal region, right? And most commonly the sciatica would be there, right? And the patient will also have the neurological claudication, which is exactly similar to that of vascular claudication. And does anyone remember what this vascular claudication is?
Pain while walking.
Exactly. Whenever you walk, you will get the pain. And
Hmm.
why is that happening? Because of a supply demand mismatch. Whenever you have any atherosclerotic plaque, right, as a result, the blood supply is decreased. Whenever patient try to walk or try to do the exercise, because the demand is now increased, but the blood supply will remain same or decreased, patient will get the pain. And this is the vascular claudication. Similar kind of pain you can also get in the neurological claudication whenever you try to walk, okay. You will have to change your posture, and as a result the nerves will get compressed. They will produce the symptoms, right? But the important difference is that this neurological claudication is postural dependent, okay. Whenever the patient bends, okay, these symptoms will kind of resolved, right? And whenever a patient straightens their back, the symptoms will again re-emerge, right? So these symptoms are totally postural dependent. Very important to note. Okay, these are basically due to a generative kind of arthritis, degenerative type of arthritis, usually having a degeneration of the bones, and as a result, the canals where the nerve's root passes, okay, originates and exits the spine, they will get narrowed, okay. And it can also be due to the intervertebral disc herniation and the degeneration, right? It occurs in a patient more than 60 years of age. And please note, you're having a hypertrophy of the ligamentum flavum, which is the most posterior ligament, right? And as a result, you will be having all these symptoms. So it is nothing but just a radiculopathy type symptoms. And the important one you need to remember that whenever the patient bends, okay, like on the car, on the cart, or maybe walking on the uphill, okay, the symptoms will be resolved. And whenever patient straightens their back, the symptoms will get worse. So the postural dependent symptoms in a very old age patients with a shooting type of pain and the sensory loss or might be the weakness also. That means neurological claudication. That means you're talking about the spinal stenosis. Any doubt?
No, thank you.
No, thank you.
Okay, so we've discussed all this seronegative spondyloarthritis. Any doubts so far? Please ask. In any of these disorders?
No,
Okay.
thank you.
So that we have discussed already. Okay, it is the interleukin 17 released by the Th1 cells, which will activate the Th17 type of cells. Okay, whatever symptoms you are having, you will be having a back pain or the buttock pain, okay, or a tenderness in the lower back. The age of the patient is very important. It is always less than 40 years of age. That means a young patient. You will be having a sacroiliitis, okay, and yeah, the symptoms will be resolved after the exercise. Okay, you will be having a very prolonged morning stiffness that improves with the use of the joint. Versus in case of multiple myeloma, you will be having a pain in the lower back again, but the patient are of old age and the stiffness will be absent. You will be having a pain at the tender insertion site, okay, and most commonly it is the Achilles tendon, which is at the back of your heel, right? You will be having a reduced chest wall expansion because of thoracic spine involvement. You will be having a decreased forward flexion because of the spine fusion, okay, because of syndesmophyte formation. On the laps, because it is an inflammatory disorder, you will get the high ESR and the CRP. You will get the ankylosis, which is the fusion of the bones, okay. You will be having a bridging syndesmophytes. We have discussed that already. A simultaneous erosion of the bone as well as the formation of the new bones occur, and we have discussed that again already, right? Then comes the SLE, the systemic lupus erythematosus. If you guys remember from the immunology lecture, we have discussed one fact about this disorder from the immunology, if anyone remember. No?
Complement.
Exactly, early complement deficiencies, right? Whenever you have a early complement deficiencies, then these complements are responsible for the clearing of the immune complexes. If these complements are not there, if they become deficient, then the clearance of the immune complexes will be decreased. And whenever the immune complexes settle on any of the tissue in your body, that will cause the inflammation, right? It will attract the neutrophils, it will attract the eosinophils and other cells, and measure the neutrophils only, right? And you will get the inflammation because of that. And that's exactly what's happening in case of SLE. You will be having a decreased immune complexes, sorry, a decreased clearance of the immune complexes, right? As well as the formation of antibodies. So it is kind of both the type 3 as well as type 2 hypersensitivity reaction. And whenever this immune complexes settle in the tissue, you will have the symptoms there. Like in case of mucosa, you will be having a mucositis. In case of heart, you will be having a pericarditis, myositis, endocarditis sometimes, right? In case of pleura, you will be having a pleuritis, right? So wherever these immune complexes deposits, you will be having a inflammation there, and that will be causing the symptoms. That that's a pathology behind the SLE. Okay, it is associated with the early complement deficiencies, right? The C1q, C4, C2. Okay, and the reasons are because of the decrease in the clearance of the immune complexes, as well as the use of these complements, right? The complements will become too much deficient because of their hyper use, right? They will be forming the immune complexes by themselves also. Okay, the important symptoms, or a very universal type of symptoms you will get is the rash, joint pain, fever. Okay, so whenever you encounter a female patient, a young female patient of reproductive age with a history of fever, joint pain, and a rash, the first thing that should come into your mind is the SLE. It is always a young female patient, okay, having a rash, joint pain, and the fever. And on the labs, what you will get is a decreased complement levels of C3, C4, C2, right? And the C1q also. Okay. So now, what are symptoms of the SLE? You know the pathology, that it is associated with the formation of autoantibodies as well as a deposition of immune complexes. Now, you will get the Liebman-Sachs endocarditis. Okay, whenever the immune complexes deposits on this endocardium, which means on the walls, you will get the endocarditis. And please note, you will get the bilateral vegetation formation. Like if you guys remember from the previous lectures, we have discussed in case of bacterial endocarditis, you will be having a formation of these vegetations, right? At the unilateral surface of the valve. Okay, it could be an upper surface, it could be a lower surface, mostly the upper surface, right, facing the auricles. Similarly, in case of Liebman-Sachs endocarditis, you will be having a bilateral deposition of these complexes, and as a result, a bilateral, on the both side of the valves, you will get the vegetation formation, and that can cause the endocarditis. It will always present you with the regurgitation murmur as well as the fever, right? Okay, and that would also put the patient on a risk of developing the bacterial endocarditis or a subacute type of bacterial endocarditis, right? Very important. Most of the mitral valves are involved. So in most of the cases, you will get the mitral or sometimes the aortic regurgitation also, right? You will be having a deposition of the immune complexes in the kidney, and there you can get the lupus nephritis, okay, which is the glomerular deposition of the anti-DNA and the DNA complexes. Okay, you will be having anti-DNA antibodies. Okay, these anti-DNA antibody will form the complexes with the DNA, and they will deposit on the tissues, on the kidney especially, and there they will cause the nephritis, which is a nephrotic syndrome. You will get nephritic syndrome, sorry, not a nephrotic. You will get the nephritic syndrome. Sometimes you can also get the nephrotic syndrome, right? So the symptoms include the hematuria, of course. You will be having a hypertension, oliguria would be there, right? So hematuria, oliguria, hypertension, and because of the nephrotic syndrome, you can also get the proteinuria. We will discuss all these things later in the renal section about the SLE also, right? So just wait for that part. Okay. And the most common type of that diffuse proliferative glomerulonephritis or the DPGN, right? Now, the common cause of the death in the SLE, it includes the renal diseases. Of course, you will be having the renal failure and then the death. Okay, infections can cause the death. Cardiovascular complications, even after the renal diseases, you will be having a cardiovascular complications like the atherosclerosis or the myocardial infarction. Patient can get the death because of that. Okay, on the labs, you will be having a positive, anti-DNA antibodies. Right, first thing, very important, you will be having the anti-DNA antibodies. You will be having the anti-Smith antibodies, positive. Okay, and just like the Sjogren syndrome, you will also be having a positive anti-RNA antibody, which is the anti-SSA type. Okay, you will be having an anti-SSA antibody positive, and the lupus also, right? And you can also get the neonatal lupus if the mother has the SLE. Okay, it can, because all these antibodies can also reach to the fetus. They can cause symptoms there. They can cause a heart block. Okay, and a diffuse type of rash would be there, right? And it can also cause the inflammation of the amniotic fluid, right? You can have the cytopenias at the birth also. Okay, so these are the symptoms for the uh, child born of the lupus mother. Okay, so now discuss the symptoms. First of all, you will be having a rash because of the deposition of the immune complexes in the skin. You will get the malar kind of rash. As you can see, this is the malar rash. And please note, it is a photosensitive rash, which means whenever the patient go to the sunlight, okay, they will get the rash there. Okay, it is a photosensitive rash, very important. They will always mention that fact in the stem, okay, that the patient is having a fever, a photosensitive rash along with the joint pain, right? You will be having a arthritis, very important. A migraine type of arthritis would be there, which means sometimes it can affect the, this knee joint, sometimes the elbow joints, sometimes the smaller joints of your hand, like the PIP, DIP, MCP types, right? You will be having a serositis, which means the inflammation of this all these serosas, right? Like the pleuritis you can get, pericarditis you can get, right? And if you guys remember the pleuritic type of chest pain, it means a chest pain which kind of worsens with the inspiration. So whenever the patient takes uh, the air, whenever they inspire the air, the patient will get the pain because of that. And as a result, the patient will have the low breathing, right? A restricted type of lung disease could be there, right? Pericarditis would be there, which means the patient will be having a fever and this, you know, uh, chest pain that improves when leaning forward, right? And all these SC segment elevations everywhere you will get. And because of this involvement of the bone marrow also, you can also get the cytopenias. Pancytopenia would be there. And because of that pancytopenia, patient will having a history of recurrent infections, bleeding complications, right? And anemia, it can lead to the fatigue, okay? And the paleness of the body, right? Very important. You will be having a deposition of all these immune complexes in the mucosas, and there you will get the ulcers. Mucositis will be there. Okay, mouth ulcers would be there. A painful mouth ulcers, very important. Painless mouth ulcers would be there, right? You will be having a renal diseases also. Okay, like the nephrotic syndromes or sometimes the nephrotic syndrome also. So patient can get the hematuria or the proteinuria. A very high creatine count would be there. You can do the renal biopsy, and there you can find a deposition of DNA anti-DNA complexes, right? And you will be having a photosensitive rash. We have discussed that. Okay, and you will be having a these antibodies. Okay, very important. You will be having a anti-Smith antibodies. You will be having a anti-DNA antibodies. And does anyone remember what the Smith proteins are?
SNPs, the proteins and SNPs.
The protein in?
SNRNP
Yeah,
SNPs.
yeah. Proteins in the SNRPs, which are your spliceosome complex. These are part of, right? You will also get the anti-nuclear antibodies, which means the antibodies against the nucleus or the ana, you can say them, right? You will be also having a neurological disorders like the seizures or the psychosis. Okay, so try to remember all these symptoms in the in a order from the upper part of the body to the lower part of the body. The most common symptoms, remember them first, like the rash, joint pain, and the fever. Okay, you can also get, you are having the involvement of every body part from head to toe, right? You will be having, all these neurological symptoms like the seizures, like the psychosis in the head. Okay, you'll be having a skin involvement. You can also have the uveitis in this case, right? You will be, and once you reach to the mucosa on the oral part, you will be having a oral ulcers. Okay, then the involvement of the lungs, you will get the pleuritis, you will get the restricted lung disease, you will get the pulmonary hypertension. Okay, then the heart, you can get the pericarditis in the heart. Bone marrow, you can get the pancytopenia, right? Joint pains you can get. On the kidneys, you can get the this nephritic or the nephrotic syndrome, right? And then comes the lab values. What you can expect on the labs, you'll be having a anti-DNA antibodies, anti-Smith antibodies, anti-phospholipid antibodies, anti-nuclear antibodies, anti-SSA antibodies, right? So these are all the things you will get in the SLE. And all that because of two things. One is a deposition of the immune complexes in different tissues of your body. And second is the formation of antibodies, right, against the cells, against the DNA of the cells, right, against the spliceosome complex of the cell. Any doubt on the SLE?
Two things there. How does the heart block work in babies? It's like,
Sorry, I didn't
yeah.
understand what it was.
Okay. In congenital heart block, that would be something like post-birth, right?
Yeah.
Like, you know about how, like, when that would present time-wise?
As soon as the patient takes the birth, they will have this heart block, right?
Okay.
Just shortly after the birth, they can have the heart block.
Okay.
That's
And
why the
then,
term congenital.
can you explain the picture on B?
Can I explain what?
The second picture?
Okay, these are discordal type of rash. You can have two type of rash. One is the malar kind, which is this one on the cheeks as well as on the nose. Okay, and these are discordal type of rash. Okay, most of the times you can only encounter this malar rash, but sometimes in the exam you can also have this discoidal type of rash. Okay, and it is mostly found on the fingers, right?
Can you type the word out in the chat box, please?
Yeah, let me just type.
Thank you so much. Oh, JK, it's on the thing. I'm okay.
Okay, I have written it down. Either you can get a discoidal type of rash or you can get a malar rash, right? Most commonly, it would be the malar rash. Sometimes you can get a discoidal rash also. Okay.
Yes, sir. Thank you.
Okay. So, any more doubt on the SLE?
No, thank you.
Okay. Now you're having other type of disorder. Okay, which is the mixed connective tissue disease, in which you're having a mixed features of the SLE, of this the dermatomyopathies, okay, and also the scleroderma, right? And these are associated with the anti-U1 RNPs. And does anyone remember where you can find the anti-U1 RNPs antibody?
SNRNP.
Yeah, exactly. These are also a part of your spliceosome complex. Please remember the spliceosome complex, it is uridine rich, right? And these antibodies are forming against the spliceosome complex. So the patient, and because they're attacking the nucleus, right? And most of these disorders, the SLE, the systemic sclerosis, or the polymyositis, dermatomyositis, okay, they are all having the antibodies against the nucleus, some part of the nucleus, some against the DNA, some against the histones, some against the, these spliceosome complex, some against the RNA. Okay, so you can have this very common features in some of the disorders also, right? So this is the mixed referred tissue type of disease. Then comes the antiphospholipid antibody syndrome. This antiphospholipid antibody can exist independently also, and it can also exist with the SLE as you can see here. Okay, one of the antibodies you can get in the SLE is the antiphospholipid antibody, right? And because of that, the patient can have the thrombosis, multiple areas of the body. Okay, the patient will have a history of deep vein thrombosis, episodic will be there. Okay, the patient will have a very previous episodes of the deep vein thrombosis also. That means the patient is having a very hypercoagulable state. Even though the patient is having a hypercoagulable state, the patient is having a very prolonged PTT. Okay, you will get the prolonged PTT only when you're having a deficiency of the clotting factors, which means the patient is at a risk of bleeding, right? But ironically, the patient is having a prolonged PTT in case of antiphospholipid antibody syndrome, right? Even though the patient is having a hypercoagulable state, the patient will be having a multiple these episodes of the deep vein thrombosis. Okay, multiple miscarriages would be there, right? So our patients with the history of thrombosis and a spontaneous abortion, you can think about the antiphospholipid antibody syndrome. You will have some findings of the lupus anticoagulant present. You will be having an anticardiolipin positive, which means you can get what type of test positive?
VDRL.
VDRL positive. Okay. If you guys remember from the microbiology lectures, we have discussed the false positive VDRL, and one of them was the antiphospholipid antibody syndrome. Second is the SLE, third is the pregnancy. Okay, some viruses can also do that, some drugs can also do that, right? So one of them is the anticardiolipin, which is found in the antiphospholipid antibody syndrome. You can also get the anti-beta, this anti-beta 2, this glycoprotein 1 antibody. Okay, and it is very specific for the antiphospholipid antibody syndrome. Okay, whenever you encounter a case of the patient having anti-beta 2 anti-beta 2 glycoprotein antibody, that means they're having this antiphospholipid antibody syndrome. Okay, the treatment includes the anticoagulation, of course, because you're having a hypercoagulable state. You can give the patient anticoagulants to prevent that conditions, right? Okay, and yeah, that would be all about the antiphospholipid antibodies. And whenever you encounter a patient having a multiple history of the abortions, as well as a multiple history of a deep vein thrombosis, you can think about this condition, right? You will always check them for the lupus anticoagulant. You will check them for the anticardiolipin antibody. You will check them for the anti-beta 2 described protein 1 antibody. All right. Any doubt?
No, thank you.
Doctor, can you please explain these lab findings of antiphospholipid syndrome? You write some, I couldn't read actually in the orange color, these lab findings.
Oh, I've just written what the FA mentioned: the lupus anticoagulant, anticardiolipin, and the anti-beta 1 glycoprotein. Sorry, beta 2 glycoprotein type 1. Okay.
All right. Thank you.
Same things which I have mentioned already.
All right. Thank you, doctor.
Okay, and you can also have the drug-induced lupus. And does anyone remember why, in case of this drug-induced lupus, you're having this anti-histone antibodies? Okay, in case of this SLE, you're having anti-DNA antibodies. Then why you're having these similar symptoms in case of drug-induced lupus and a normal SLE? Anyone remember? We have talked about this in a very first lecture.
Because histone are closely linked with the
They're
DNA.
closely linked. Yeah.
Because the histones are very closely linked with the DNA, right? You can have a very similar symptoms in both of the disorders, but please note the SLE will always present only in the females. Okay, especially for the this step 1 exam, right? And the drug-induced lupus, it could be a female or it could be a male, and the patient must be having a history of the drug use, right? And the drug includes a hydrolazine, isoniazid, procainamide, minocycline, TNF alpha inhibitors. Okay, very important. And you can just remember the mnemonic HIP, this hydrolazine, isoniazid, and the procainamide. Okay, and one more drug which is alpha methyl dopa. It is also very important. I forgot to mention it here. Okay, so remember the mnemonic HIPA, which is hydrolazine, isoniazid, procainamide, and the alpha methyl dopa. These 4 drugs are very important for the drug-induced lupus. And all of these 4 drugs, they undergo what kind of metabolism?
Acetylation.
Acetylation, right? Very important. You will be having an anti-histone antibody positive. You will be having a fatigue, fever, joint pain, rash, okay, inflammation of the pleuras, pericardium, and all the features of the SLE, right? And it would be a male or patient. And the hint you can get, right? Okay, then you have the polymyalgia rheumatica, which is the pain and the stiffness of the proximal muscle. If you guys remember the previous lectures, we have discussed about the giant cell this giant cell arthritis, right? And we have discussed that one of the feature of the giant cell arthritis is the polymyalgia rheumatica, in which patient will be having a proximal pain in the muscles, right? Whenever patient try to move the arm, okay, above the head of the patient, right? While combing or while doing something overhead activities, the patient will get the pain because of that, right? On the hips, patient can get the pain, and they generally present you with a very difficulty in standing from the chair, a pain in standing from the chair, or pain while climbing the stairs, they will tell you, right? And because it is associated with the vasculitis, it will has the other features of the vasculitis also. Systemic signs and symptoms of the inflammation, right? Like this, uh, the fever, fatigue, okay, they will also be there. Okay, and please note, it won't cause any muscle weakness. It is just a pain, not a weakness in the muscle. Very important to note. And you will be having a, because it is associated with the inflammation, you will be having a high ESR, high CRP, okay, and the creatine kinase levels are normal. Okay, it is not the inflammation of the muscles, please note. It's just you're having a pain in the muscles and the stiffness in the muscle. Okay, and that's why this name doesn't mention anywhere inflammation in it, right? It's just a pain in the muscle, not an inflammation. That's why you're having a normal CK levels. Okay, you're having a normal, the power of the muscle will be normal, no weakness is there. Okay, just a pain and the stiffness. Okay, and it is associated with the giant cell or the temporal arteritis. Okay, and so what are the treatment? You will always give the patient low dose glucocorticoids. Any doubt on this page?
I have one question.
Do ask.
In polymyalgia rheumatica, the increased ESR is due to uh, giant cell arteritis or due to polymyalgia rheumatica itself?
Due to giant cell arteritis, because this condition is always associated with the giant cell arteritis, right?
Yeah, yeah.
So that's why we'll get the high ESR because of the vasculitis mainly.
Okay, got it. Thank you.
Just give me a second, guys. Yeah, so any more doubt on the polymyalgia rheumatica?
No, thank you.
Okay. So now comes the fibromyalgia. Yeah. So this fibromyalgia, it is basically it is most common in the woman of the age 20 to 50 years old. Okay, and the patient will be having a musculoskeletal type of pain. Okay, just like the polymyalgia rheumatica, you'll be having a proximal pain in the muscles. Okay, so the patient will present you with a pain in the overhead activities or pain while walking upstairs. Okay, and the pain while sitting up from the chair, right? So a proximal muscle pain would be there that involves the shoulder and the pectoral girdle, right, of the patient. Along with that, the patient will also have the tender points, which means whenever you palpate the patient, okay, at certain points, a patient can feel the pain. Okay, so on the examinations, there's some locations are present in which the patient will have the pain, and the locations are generally at the bony prominences or at the soft tissues, right? Along with that, the patient will also have the stiffness, paresthesias, and a history of depression is very important. Okay, these are generally seen in the females who are having depression, right? So they will be taking any antidepressant therapy. It is another type of hint you can get from that this stem. So it would be a patient who is having all this pain in the muscles and all these things, and they will mention that the patient is also taking a tricyclic antidepressant. So that's how you know that the patient must be having a history of depression and a history of depression along with all these symptoms like the poor sleep, fatigue, paresthesias, stiffness, muscle pain, right? They all hint towards the fibromyalgia. Okay, and please note it is not associated with the inflammation, so the ESR is normal. Okay, you won't be having any kind of this synovial swelling. It's just you're having the muscle pain, you're having the joint pain, you're having the bone pain also, right? Multiple tender points are there, stiffness are there, paresthesias are there, right? And a history of poor sleep is also there. Sleeplessness would be there, right? And yeah, the patient will also have the concentration problems, which is the fibro fog. Okay, you can have the cognitive disturbances. Okay, they will tell you that they have a very poor memorization or they have a poor concentration, right? They will always mention that history. So it is again a very important thing. A poor concentration, poor memory, right? They also hints toward this condition. So a patient having depression, poor memory, sleep problems, now this proximal muscle pain and the stiffness, that means they're talking about the fibromyalgia. They can ask you about the lab values. Please note the ESR would be normal. Okay, so any kind of this inflammatory etiology is absent, right? It is not an inflammatory etiology. Without inflammation, you will having all these symptoms, right? So that's about the fibromyalgia. Any doubt?
No, thank you.
And please note, it is all due to a psychological disturbance in the brain. Okay, and the brain is producing these symptoms. Okay, now comes the polymyositis and dermatomyositis. Okay, it is basically, as the name suggests, it is the myositis. That means the inflammation of your muscles you will get. And the inflammation you will get is in the skeletal muscles, which are the voluntary muscles of your body. Okay, you will get the inflammation of the skeletal muscles in case of the polymyositis and the dermatomyositis. Okay, you will have the anti-nuclear antibody positive, and it is kind of a non-specific type of marker because you can get the anti-nuclear antibody positive in the SLE also, in the Sjogren syndrome also, right? In other conditions also, right? So it is kind of a non-specific, you can say a sensitive type of marker. You will be, because it is an inflammation of the muscles. Okay, you will have the destruction of the muscle fibers or the muscle cells, and as a result, the patient can also get a high creatine kinase level, right? So these are the non-specific markers. Specific markers include the anti-Jo1 antibodies, okay, which is against the tRNA synthetase. Okay, it is the antibody against the tRNA synthetase. You will also have the anti-signal recognition peptide antibody. Okay, if you guys remember, whenever whenever the mRNA exits the nucleus, okay, these signal recognition peptides are present to recognize the mRNA and halt the translocation until this RNA reaches to the rough endoplasmic reticulum and the translation starts there, right? So you will get the antibody formation against these SRPs. You will also have the anti-MI2 antibody, which is the anti-helicase antibody. We have discussed that already in the biochem lectures about the anti-helicase antibody. Okay. So these are all the antibodies you will get in both the conditions. Okay. Let's discuss the first about the polymyositis. Okay. In the polymyositis, you're having an inflammation on the endomysium. Okay, very important to note, you're having the inflammation of the endomysium, which is the innermost layer of a muscle fiber, right? It is kind of the layer around multiple muscle fibers. Okay, you will get the inflammation there, right? And please note that the inflammation is CD8 T cell mediated. Okay, and it involves mostly the shoulders. So the patient again cannot comb the hairs. Okay, they cannot sit up from the chair, right? And with with all these symptoms, if the inflammation progresses, it can also include other skeletal muscles like the heart. You can get the myocarditis. Okay, and the death can occur because of the myocarditis again. Patient can have the inflammation in the skeletal muscles of the esophagus, right, in the proximal esophagus, right, and as a result, you can get the dysphagia, right? A patient with the dysphagia will be there. Okay, the pulmonary muscles can also be affected. They will also be inflamed, and as a result, patient can get the restricted lung disease also in case of that, right? You will get the decrease in the muscle movement, right? Aspiration could be there because of that. So all these are the symptoms of the polymyositis. Okay, dermatomyositis, you will be having a kind of the superficial inflammation of the muscles. Okay, it is a perimysial inflammation. Okay, it affects the perimysium layer of the muscles. Okay, and so that you will be having both the inflammation of the skin as well as the inflammation of the muscles. Okay, so both the skin symptoms as well as the muscle symptoms are present. So what are the skin symptoms? You will get first the rash on the garden papules. Okay, very important. You will get this reddish kind of rash on the garden papules, right? As you can see on the fingers. You will have a heliotropic rash, which is a rash on the eyelid. Okay, you'll be having a shawl face rash, which is a rash on the unilateral surface of the face, as you can see, right? So these are all the skin findings you will get on dermatomyositis. Apart from that, you will also have the edema of the eyes. Okay, you will have the edema of the eyes, the structure surrounding the eyes, you will get the edema there. Okay, so these are the skin findings, and the muscle findings are similar to that of polymyositis. You'll be having a proximal muscle weakness, you'll be having a proximal muscle pain, right? You'll be having a dysphagia, you will be having a pulmonary aspiration or the restricted type of lung disease, you will get a myocarditis, and that can occur because of that. But please note that this condition is associated with our CD4 T cells. It is mediated by the CD4 T cells. Very important. Okay. And please note that whenever you have the polymyositis or the dermatomyositis, it is there are very high chances that the patient is also having some kind of a cancer, and it is mostly the ovarian cancer. Please note that this dermatomyositis is a paraneoplastic syndrome, right? It is associated with the lung cancer or the ovarian cancer, mainly the ovarian adenocarcinoma. So Stephen can ask you this fact also. If you encounter a patient having a dermatomyositis, what other test you need to run in the patient? Okay, it would be the test for the ovarian cancer. You need to make sure that the patient is not having ovarian cancer, right? Very important. And yeah, that would be all about the dermatomyositis and the polymyositis. Any doubt?
No, thank you.
Then you also have the inclusion body myositis. Although it is not very much important, but if you encounter a case on this condition, you can easily get this question right. So please note that it is an inclusion body myositis. It is seen in the patients who are of a very old age, more than 50 years, right? And unlike in case of this dermatomyositis or the polymyositis, in which you're having a proximal muscle pain, right? In case of this inclusion body myositis, you're having a distal muscle weakness and pain. Okay, and whenever you do the biopsy of the muscles of the distal region, what you can see some inclusions body, okay, in the cytoplasmic vacuoles would be there, right? And amyloidosis can also happen in this disorder. So just one thing you need to remember, it is old age, it is seen in the old age patients, and the patient will be having a distal muscle weakness because of that. So these are the inclusion body myositis. Here, one thing also to remember about the costochondritis, as the name suggests, it is the inflammation at the costochondral junction, okay, which is around around 4 centimeter distance from the central sternum. You have the sternum in the center. Okay, 4 centimeter lateral to the sternum, you're having this costochondral junction. Okay, and the inflammation there will leads to the costochondritis. Okay, and this condition can mimic the heart attack. You will be having a very severe kind of chest pain at the lateral of the sternum. Okay, and whenever you try to breathe, you will have the pain there. Okay, whenever you try to move the rib cage, you will have the pain there. So the pain will be associated with any kind of movement of the rib cage, right? And when you palpate the patient over that painful area, you can get that tenderness over there. Okay, whenever you palpate the patient over these areas, you will get the tenderness at the same location you're having the pain. So a pain as well as tenderness at the same location, that means they're talking about the costochondritis. Causes can include a trauma, scoliosis, ankylosing spondylitis can also cause that condition, right? And can it can also be due to the infection of the costochondral joint, right? And please note the diagnosis is always made clinically. Okay, you do not have any more tests for that. Okay, although you can do the ESR and other tests, but they are all non-specific ones. Okay, chest X-ray would be absolutely normal. Okay, and please note diagnosis is always clinically made. You will look for the symptoms of the patient and you will make a diagnosis without running any test or something, right? And the symptoms include the chest pain, which is around 4 centimeter lateral to the sternum. Okay, and you will get the tenderness on the palpation at the same location. and the pain occurs whenever you move the rib cage, like with the inspiration or by changing your position, right? You can get the pains. So, any doubt on the costochondritis?
No, thank you.
No, thank you.
Now comes the neuromuscular junction diseases. We have two diseases. One is the myasthenia gravis, and second is the Lambert-Eaton myasthenic syndrome. Okay. In case of myasthenia gravis, you're having the antibodies against the acetylcholine receptors, which are involved in the muscle contraction. While in case of Lambert-Eaton syndrome, you're having the antibodies against the presynaptic, please note the location, presynaptic calcium channels, which are responsible for the release of acetylcholine. So in one condition, you're having a decreased response to the acetylcholine, and in second condition, you're having a decreased release of the acetylcholine. Okay, very important. Both of these conditions are kind of type 2 hypersensitivity reactions, right? Very important to note. So what are symptoms of the myasthenia gravis? Because of this antibody formation against the acetylcholine receptors, which are the post-synaptic receptors, okay, you will have the fatigable muscle weakness, which means whenever you use the muscle, okay, you will have the progressive type of weakness. Okay, at the rest, you won't have any weakness. It would be symptoms would be absolutely normal. As long as you use the muscles, you will get the weakness, very kind of a severe kind of weakness, right? So a weakness would be there with the use. And please note, just give me a thing, just give me a second. Yeah. Please note you're having a bulbar tract muscle this bulbar tract weakness first. That means all of the cranial nerves which are supplying your facial regions, okay, you call them the bulbar tract, right? You will be having an inflammation or the or this disorder will affect these areas first. Okay, that means you're having the weakness in the area supplied by the cranial nerve 7th or the facial nerve, I must say. Okay, you will be having a ptosis because of that. You will be having a diplopia because of this third nerve. Okay, you will be having a proximal muscle weakness. Okay, you will be having an asymmetric kind of smile. Okay, you will be having a dysphagia. We have discussed that. And apart from that, once you have these symptoms, okay, and the disease now progress, and now it will affect the peripheral muscles also, right? Like the respiratory muscles. And because of the respiratory muscle involvement, you can get the restricted type of lung disease. You will get the high CO2 count in the lungs, right? You will be having a very rapid this the breath rate will be very much high of the patient, okay, and you will be having hypoventilation, right? Dyspnea would be there, right? Dysphagia will be there. We have discussed that because of the bulbar muscle weakness, okay. Difficulty chewing would be there, right? But please note that reflexes are always normal. You will be having a normal tendon reflex because the ACH is normally releasing from the neurons, right? So whatever the ACH receptors are available, okay, this ACH will stimulate them and it will cause the contraction, right? So the tendon reflexes are absolutely normal, okay, but the muscle weakness is there that worsens with the use of the muscle group. As long as you use the muscle, you will get the symptoms because of that, okay. So the extraocular symptoms include the ptosis and diplopia, okay, because of this third nerve involvement. Okay, you will get the bulbar muscle weakness because of the cranial nerve 7th or the facial nerve involvement. You will get a dysphagia, you will get a dyspnea, right? Because of the facial nerve, you will get a drooping of the mouth, drooping at the corner of the mouth, you will get, right? So these are all the symptoms of the myasthenia gravis. Because of the proximal muscle weakness, you will get the difficulty combing the hair, difficulty sitting up from the chair, difficulty climbing up the stairs, right? A proximal muscle weakness. These conditions, the myasthenia gravis is mainly associated with the thymoma. Okay, so you always need to do the X-ray of the patient, the chest X-ray of the patient to make sure that the patient is not having any thymoma. Okay, or sometimes the patient can also have the thymic hyperplasia. Okay, if you give the patient the acetylcholine esterase inhibitor, which is basically the enzyme responsible for the degradation of the acetylcholine. If you degrade this enzyme, right, in that case, you can have a high level of acetylcholine, right? And that would reverse the symptoms of the myasthenia gravis. Okay, so that's how you develop the penicillin test for the myasthenia gravis, in which you give the patient adrophonium. And the adrophonium is a very short acting agent. You give this agent to the patient, and if the symptoms of the patient improves, that means the patient is having a myasthenia gravis. Okay, very important. Or if you give the patient adrophonium and the symptoms are were not resolved, in that case the patient is having a cholinergic crisis because of too much release of the acetylcholine sometimes, or a presence of any muscarinic agonist. Okay, you will be having a receptor desensitization, and because of that you can have the symptoms similar to that of myasthenia gravis. Okay, the only thing you can do is the penicillin test, in which you give the patient adrophonium. If the symptoms improved, that means the patient is having a myasthenia gravis. If the symptoms worsen after giving that, that means the patient is having a cholinergic crisis, right? So yeah, and because of these antibodies, the antibodies will first attack on these receptors, and as a result, the the internalization of these receptors will occur, and after the internalization, the degradation of these receptors will occur. So first is the internalization of the receptors inside the cell, and then the degradation will happen because of these antibodies against the receptors, right? So any doubt on this myasthenia gravis so
Could you
far?
please explain why cholinergic crisis is seen over here?
Why?
Cholinergic crisis is seen over here.
Why cholinergic crisis is seen? Sorry, I didn't understand.
You said something about cholinergic crisis. Could you please explain it once again?
Okay. See what happens if you're having a too much levels of all these muscarinic agonists, this agonist in the blood, right? Like if you give the patient treatment for the pyridostigmine, for say, okay, and you give too much of the pyridostigmine to the patient, then the receptor desensitization will occur, right?
Yeah.
And as a result, patient will again get the weakness because of that.
Yes.
And if you even give the patient more this drug, then what gonna happen? Does it improve my symptoms?
No.
Of course not, right? And that's why that's known as a cholinergic crisis. Whenever you have too much of the cholinergic agents, okay, like the pyridostigmine or any other agent, the pilocarpine or other stimulating agents, okay, then the receptor desensitization will occur, and as a result, the muscles won't be responding to the acetylcholine anymore, right? And as a result, you will get the weakness because of that, right? In order to differentiate this condition with the myasthenia gravis, you can give the patient adrophonium. If after giving the adrophonium, if the condition improves, that means the patient is having a deficiency of this acetylcholine, right? And if the condition worsen, that means you're having a too much stimulation of the receptors, right?
Yes. Yes.
So this is a very important test, the adrophonium test, or also known as the penicillin test for that. Okay. And please note, step one can also mention this option that in the myasthenia gravis, they will give you a patient with the myasthenia gravis with all these symptoms, and they will ask you what is happening in the patient. So it is the receptor internalization. After that, the receptor degradation will occur because of these antibodies against these receptors, right? And please note the amplitude of the motor and plate potential is decreased, okay, because no longer you're having the hormone which is stimulating the receptors to contract, right? So the amplitude will be decreased, very important, at the motor and plate potential, right? But please note that the action potential of the muscle will always remains the same, because if you have the acetylcholine, okay, which is stimulating these receptors, then you can have a full-fledged contraction, right? Muscles are normal, it's just the receptors are not stimulating, right?
Yeah.
So as a result, you will be having a normal action potential of the muscle, because muscles are absolutely fine, but you're having a decreased amplitude of the motor and plate potential, which is responsible for causing the contraction, right? Very important to note that again. And what other test you can do? You will ask the patient to focus on a point, okay? And you will see as the patient focus on the point, after some time, the vision will become very blurry, or the diplopia of the patient will occur. Because in focusing, you need the cranial of 3, right, to stimulate all these extraocular muscles so that you can focus on a point. Because you're having a myasthenia gravis, with the use of all these muscles, with the use of the CN3 of the third cranial nerve, right, you'll be having a you will be having a progressive weakness, right? And after some time, the patient will complain you of the blurring of the vision or the diplopia. So this is again a test you can do on the examination to check for the myasthenia gravis. And please note, whenever you give the patient ice packs or any cold therapy, then the inflammation is decreased. So the patient generally also tell you that after using some ice pack, patient will having an improvement of the symptoms. Okay, because after applying the ice packs, the antibodies will be decreased, right? The inflammation will be decreased. So this will improve the symptoms. So that would be all about the myasthenia gravis. Any doubt? Now, please ask.
No, thank you.
Because of the hyperventilation, you will get a low pH or the acidic pH, respiratory acidosis will be there, metabolic compromise, this compensation will be there, right? So you'll be having a metabolic alkalosis and the respiratory acidosis. Because of that, high level of CO2 will be there, low level of oxygen will be there. Patient and the stepman can also ask you what you can expect in the kidneys. Okay, so kidney will be reabsorbing all the bicarbonate and losing all these hydrogen ions, right? So they can go one step ahead and they will ask you this also. So you just need to remember that in case of myasthenia gravis, you're having a pulmonary hyperventilation, and because of that, you're having a respiratory acidosis, right? So we will take a short break here, and after the break, we will discuss the Lambert-Eaton syndrome. Is that okay?
Yes.
Yes.
Okay. Now comes the Lambert-Eaton myasthenic syndrome, in which you're having antibodies against the P-synaptic calcium channels, and as a result, the acetylcholine won't be released. And if the acetylcholine won't be released, then in that case, you cannot have the contraction, right? Even you cannot have the reflexes, right? As a result, the reflexes will be decreased in case of Lambert-Eaton syndrome. First important thing, okay? You will be having a proximal muscle weakness just like the myasthenia gravis, okay? But the weakness, it involves the lower limb first, then the upper limbs. Okay, in case of myasthenia gravis, you will be having a bulbar weakness first, means the facial expressions, the dysphagia, the diplopia, and all other things. In case of Lambert-Eaton syndrome, you're having a lower limb weakness first. Okay, that means a patient present you with a history of this a difficulty in climbing up from the chair, right? This will be the first symptom of the patient, right? Hyporeflexia will be there, but in case of myasthenia gravis, you'll be having a normal reflexes. Okay, reflexes in case of Lambert-Eaton syndrome will improve with the muscle use, or all these symptoms will improve with the muscle use, because as you use a muscle, you'll be using more calcium channels, right? So more pressure will be put on the muscle on these nerves to release the acetylcholine. So with the use, you will have the improve in the muscle weakness, right? And this condition is associated with the small cell lung cancer, a very important thing. Now, apart from the muscle symptoms, you can also have the autonomic symptoms, because the acetylcholine is also responsible for stimulation of the muscarinic receptors, right? So you will also get the autonomic symptoms like the dry eyes, dry mouth, okay, loss of sweating, right, high temperature. All these symptoms are also associated with the Lambert-Eaton syndrome. Okay, so a hyperreflexia, muscle weakness, which is in the lower limb first. Okay, and the autonomic symptoms, these are all present in the Lambert-Eaton syndrome. Okay, and it is antibodies form against the calcium channel receptors. Any doubt?
No, thank you.
Okay, so that would be all about the Lambert-Eaton syndrome. And just can anyone tell me how you can differentiate between the Lambert-Eaton syndrome and the botulinism?
With repetitive movement, Lambert-Eaton should get better.
Yeah, sorry.
With repetitive movement, Lambert-Eaton should get better.
With the movement, both the conditions will get better.
Mm,
If you use the muscles, then the conditions will improve in both Lambert-Eaton as well as in the botulinism.
Oh,
So try another difference.
level of acid. Oh, they would both also have the same.
Both conditions are very much similar to each other. Anyone want to try? Difference between Lambert-Eaton syndrome and the botulism in terms of this findings, the symptoms, the clinical features. Any difference?
Maybe history of food poisoning, something.
History, okay. This could help you. History, okay.
Botulism give you upper limb before lower limb?
Exactly. Botulism will give you the bulbar weakness first. So a bulbar weakness along with the autonomic symptoms, that means you're having the botulism. Okay. A lower limb weakness along with the autonomic symptoms, that means you're having the Lambert-Eaton syndrome. Okay. And the weakness which improves with the use, that means either the Lambert-Eaton syndrome or the botulism. But the condition which worsens with the use, that means it is the myasthenia gravis, and myasthenia gravis do not have any muscarinic symptoms, right? Is that okay? Please respond. Should I repeat it again?
That's okay.
Okay, now comes the Raynaud phenomena, in which you're having a decreased blood flow to the skin. Okay, and it is because of the vasospasm or some kind of a blockage in the arterial supply to the fingers. Now, as a result, whenever you put the fingers in the cold, okay, the vasospasm will occur. Okay, the blood supply is already very much decreased in the fingers. Above that, you're having a vasospasms. Okay, the blood supply will be severely decreased in the fingers. And as a result, what you will get is a color changes. First, you will get the ischemia, okay, which is the fingers will become very much white. Okay, then the hypoxia occur, that will make the fingers blue, and then then the reinfusion occurs whenever you put the fingers again back into the warmth. Okay, so the red color of the skin will occur, of this fingers will occur. Okay, so the first is the white, then the blue, and then the red. That will be seen in the Raynaud's phenomena. Okay, it is called the Raynaud's disease whenever it is primary or whenever it is idiopathic. Okay, it is called the Raynaud's syndrome whenever it is associated with any other disorder. Okay, whenever it is due to any other disorder like the vasculitis. If you guys remember, what kind of vasculitis can have a Raynaud's phenomena?
Burgess disease.
Burgess disease. Very good. Okay, then the SLE can also have that. Crest syndrome can also have that. Okay, please remember these three diseases. Okay, and the mixed connective tissue disease. Okay, the four diseases are there: the Burgess disease, mixed connective tissue disease, SLE, and the Crest syndromes. They all are associated with the Raynaud's phenomena. Okay, and because of the ischemia, because of this loss of blood supply, the patient can also get the ulcerations, also necrosis at the fingertips, because the distal regions will be affected first. Okay, so they can also have the digit ulcerations at the tip of the fingers. Okay, and the condition will be treated with the calcium channel blockers, right? So it is all due to a decreased blood supply to the fingers, right? And the fingertips will be affected first. Ulcers will be there, skin changes will be there, right? Due to the vasospasms. Okay, and vasodilator agents will be very much helpful. Any doubt on that Raynaud's phenomena?
No, thank you.
Okay, so we have discussed all these exacerbations of the myasthenia gravis patient and the Telcelen test that differentiates between the low dose, or in case of myasthenia gravis, and the cholinergic crisis, right? If you get the improvement of the symptoms, that means it was the low dose or the myasthenia gravis. If you're having a too much dose of the hydrophonium, okay, that means you're having a cholinergic crisis. Okay, and if you give the patient any other muscarinic agonist, then we have a worsening of the symptoms, right? So the hydrophonium test or the tension test is very important test to differentiate between these two conditions, right? Okay, so any doubt on this page?
No, thank you.
Okay, then comes the scleroderma. Okay, and this condition is only due to a excessive deposition of the collagen in the tissues, right? Because of excessive deposition of the collagen, you're having this disorder. Okay, it is also known as the systemic sclerosis, which means you're having a thickness in the body, right? And this thickness is due to the collagen deposition, right? It is basically autoimmunity. Okay, it is non-inflammatory condition, right? And you will having a vasculopathy in this condition along with the collagen deposition, right? Because of the autoimmunity, you will be having a T cell activation that releases the TGF beta. And you guys already know that whenever you have a high level of TGF beta, you will be having a very high collagen deposition, right? And that can lead to the fibrosis, that can lead to the thickening of the tissues, right? So because of this this level of TGF beta, you will be having a fibroblast stimulation, which causes a collagen deposition with the fibrosis, as you can see. The manifestations include the sclerosis of the skin, which means a thickening of the skin, and that's because of the deposition of collagen in the skin. You will be having a puffy, taut skin, okay, without the wrinkles. Because of this skin thickening, the wrinkles will be lost. Okay, very important to note. You will also have the other organ involvements like the lungs, like the kidneys, like the heart. Okay, you will be having a fibrosis in the lungs. You will be having a fibrosis in the kidney. You will be having a fibrosis in the heart also, right? So you can have a scleroderma renal crisis, okay, and you treat them with the ACE inhibitors because of this vasculopathy and the thickening of the vessels, blood vessels. You will be having a decreased blood supply to the kidneys first, right? And secondarily, because this efferent arteriole will be very much thickened, okay, or the sclerorized. As a result, the GFR will be kind of very much increased. The pressure on the glomerulus will be increased, just like in case of diabetes. Okay, you'll be having a proliferation of this glomerulus that can damage the kidney even more. So the ACE inhibitors are very much protective. Okay, in the lungs, you can have the pulmonary fibrosis because of this collagen deposition in the interstitium, right? You can have a pulmonary hypertension because of that. In the GI tract, you can have a esophageal dismotility because of fibrosis of the smooth muscles of the esophagus, right? And the smooth muscles are present in the lower two-thirds of the esophagus, right? So you will be having a dysphagia. And because of the lower esophageal sphincter involvement, you can also have the regurgitation, like the GERD. Okay, so a GERD can also be associated with the scleroderma. Okay, what findings you will get on the biopsy are the fibrosis of the muscles and the atrophy of the muscles, right? Cardiovascular involvements can lead to the dilated cardiomyopathy because of the fibrosis, right? So you have two type of scleroderma. One is a diffuse type and one is a limited type. The limited type is limited to certain tissues only, okay, and majorly on the skin, right? But the diffuse type, it involves every organ, right? It has a very widespread skin involvement along with the early visceral involvement, right? And it is associated with the anti-scleroderma 70 antibody, which is the anti-DNA topoisomerase 1 antibody, right? Is the antibody against the topoisomerase 1? And does anyone remember the function of topoisomerase 1?
Reduces supercoiling.
Yeah, it will reduce the supercoiling. Exactly. You'll be having antibodies against them, right? And you can also have the antibodies against the RNA polymerase 3. Okay. So these two antibodies will be found in the diffuse scleroderma. And please note, you will be having the early visceral involvement, which means the renal involvement, the pulmonary involvement, the heart involvement, and the esophageal involvement, right? Then you have the limited scleroderma, which is also known as a CREST syndrome. Okay, you'll be having a calcinosis cutis, okay, which is the calcium deposition in the skin, right? You'll be having an anti-centromere antibody, okay. You will be having a Raynaud's phenomenon, esophageal dysmotility because of fibrosis of the lower esophageal smooth muscles. Okay, you will be having a sclerodactyly, okay, which means you will be having a thickening of the skin of the fingers. You will be having a telangiectasias also, right? And this is all the CREST syndrome. Okay, so the calcinosis cutis, which means the calcium deposition at the fingertips. You will get the fingertip ulcers also because of that. Esophageal dysmotility because of atrophy and the fibrosis of the lower two-thirds of the smooth muscles. You will get the GERD also, right? You will get the sclerodactyly, which means the thickening of the skin of the hand. You will get the telangiectasias, which means the blanching, spider-like kind of, this blood vessel lesions all over the skin, right? So these are all the features of the limited scleroderma. Okay. And please note, if the step when mentioned about the histology, what you will get is the expansion of the dermal layer. Okay. On the biopsy of the patient of the skin, what you will get is the expansion of the dermal layer of the skin because of the collagen deposition, as well as the atrophy of the interdermal tissue. Because, because of too much collagen deposition, all these follicles, the hair follicles or the sweat glands, they will be lost, right? So the patient will lose the dermal appendages like the hairs, like the sweat glands, right? And that's why you can see all this skin, it will divide off any hair. Okay, a very smooth and very thickened skin will be there. Pulmonary hypertension can also occur, right? Very much important. And yeah, that would be all about this disorder. Any doubt?
No, thank you.
Just note you will get the atrophy and the fibrosis on the biopsy of the patient with the scleroderma, right? Okay, so we are done with the rheumatology and now we are about to discuss the dermatology now. Okay. So first of all, you need to know the layers of the skin. Okay, on the outermost, you're having the stratum corneum. Then you're having the stratum lucidum, then the stratum granulosum, then the stratum spinosum, and then the stratum basilis. And you can remember all these layers in the sequence with the help of this mnemonic. Come, let's get sunburned. Okay, come for the corneum, let for the lucidum, okay, get for the granulosum, sun for the spinosum, and burn for the basilis. Okay, and please note that this stratum corneum is a nucleated cell layer. The cells which are present here, they are devoid of any nucleus. Okay, very important. And if the nucleus is present in this layer, you call it a condition known as the parakeratosis. Okay, this parakeratosis refers to a condition in which you're having a nucleus in the stratum corneum. Okay, it is kind of a dead cell layer, you can say, normally, right? So these are the layers of the skin. Okay, so any doubt on this page so far?
No, thank you.
No.
Okay, then you need to know how these different cells, okay, are kind of joined together, are adhere to each other, right? How this happens? So this is happening because of the epithelial cell junctions, and these cell junctions are found in your skin. These cell junctions are found in your GI tract. Okay, these junctions are found in your brain, in your muscles, right? Everywhere these junctions are found, right? The first one are the tight junctions, okay, which are made up of the zona claudins and the zona occludens. These are the proteins which form these tight junctions, okay, and they prevent any paracellular movement, which means the movement of fluids in between the cell. If you guys remember the blood-brain barrier and the blood placenta barrier, right, the blood testis barrier, right, they will prevent any kind of entry of the cells in these tissues, right, in the brain, in the testes, right?
Yeah.
And why these cell movements are prevented? It is because of the these tight junctions, which prevent any kind of intercellular movement, right, or the paracellular movement, which means a movement between the cells would be prevented. So the only way by which the substrate or a cell can pass these junctions, okay, these barriers, it by entering in the cell, okay, and then reach to the other side. And those substances which cannot enter the cell, which cannot cross these the plasma membrane, okay, they cannot enter the tissue because of the presence of these tight junctions. Okay, so remember that these tight junctions are made up of zona occludens and the zona claudens, and they will prevent the paracellular movement of any substrate, any cell, right? Then comes the adherent junctions. Okay, as you can see, these are the adherent junctions. And please note they are calcium dependent junctions. Whenever the calcium is present, only these junctions will be functionable then, right? If you loses the calcium, which means if you get the hypocalcemia, okay, then these junctions will be inhibited and now the cell can move freely. Okay, very important to know. This step one can give you a experimental type of question over that. It would be a patient or it would be a scientist who is experimenting, okay, and it decreases the calcium level in the environment, and what you will see is the movement of cell of the tissues, right? They will lose their adherent junctions. And why is that? Because of, because these adherent junctions, they are dependent upon the calcium for their function, right? And please note that they will connect the actin cytoskeleton of the adjacent cell, which means, these junctions are connected with the actin for tubules on this cell and the actin tubules on this cell. And that's how they connect two different cells together, right? So they connect the actin cytoskeletons of these adjacent cells, right? And whenever you have a loss of EK adherent, if you remember the general pathology lectures about the neoplasia, we have discussed the loss of EK adherent, and as a result, now these cells can move freely within the tissue, right? And they will now penetrate the basement membrane, and they will then get the metastasis, right? So the loss of EK adherent is very much important for the metastasis of the tumor. Then you have the desmosomes, okay, which is kind of similar to the adherent junctions again. But if you look, the adherent junctions are kind of connecting the what kind of tubules, what kind of cytoskeletons?
Microfilaments.
Yeah, exactly, the microfilaments. But the desmosomes are connecting the intermediate filaments. Very important. Desmosomes are connecting the intermediate filaments of two cells together, and that's how they're keeping two cells joined to each other, right? And whenever you have antibodies against these desmolagen or the desmosomes, okay, you can get the pemphigus vulgaris because of that. Okay, antibody against the desmosomes can lead to the pemphigus vulgaris. Okay, then you have the gap junctions. Okay, and the gap junctions, as you can see, they are made up of the connexons. Okay, and these connections will help the cells in connecting to each other. Okay, they will help transfer the information in between the adjacent cells, and that's how you will get a very coordinated contraction and a coordinated movement of the cells. Okay, whenever we talk about the contraction of the heart muscles, whenever we talk about the contraction in the labor, right, they're all possible because of the connexons or the gap junction in between the cells, so that the ions can easily pass through the cells and cells can communicate with each other, right? Then you have the hemidesmosomes, which are kind of the desmosomes, but they're attached, they attaches the cell or the epithelial surface, okay, with the basement membrane or the basal lamina, I must say. Okay, they will connect the basement membrane or the basal lamina of the tissue with the epithelial cells, right? For example, in case of skin, it connects to the keratin in the basal cells to the underlying basement membrane. Okay, you have the stratum basalis. Okay, and this stratum basalis, it will be connected to the basement membrane with the help of these hemidesmosomes. And please note that the hemidesmosomes are not calcium dependent, while the desmosomes and these adherent junctions, they are calcium dependent. Whenever the calcium is not available, okay, these junctions are kind of lost, and the this connection between the two cells will be lost. Cell can easily move freely within the the intercellular space, right? So that's about the hemidesmosomes. Okay, then finally you have these integrins, which are kind of a membrane proteins. That these proteins are found in the cell membrane. Okay, and they will maintain the integrity of the basolateral membrane by binding to the collagen, lamin, fibronectin at the basement membrane. So you have the basement membrane, okay, and which is made up of the collagen, of course, and then you have the cell, which have the integrins, okay, and now this integrin will bind to the fibronectin, lamin. Okay, please note the word lamin. It is laminin. It is okay, very important. So the fibronectin, laminin, and the collagen will be connected with the help of this integrin to the cell, right? And now, whenever any kind of tumor cell want to metastasize, it first need to attach to the basement membrane, right? And how does this tumor cell will attach to the basement membrane? It is with the help of the integrins and the fibronectins. Okay, very important. And yeah, that's why they're involved in the metastasis, because the cell, the tumor cell, will connect it to the basement membrane only with the help of these integrins. Now, using the integrins, they will bind to the fibronectin or the laminin on the basement membrane. They will release all these hydrolytic enzymes. Okay, the metalloproteinases, they will digest this basement membrane, and now the cell can easily cause the metastasis, right? So, do remember the function of these integrins. It is to bind to the fibronectin and the laminin on the collagen or the extracellular membrane. Okay. Any doubt on the junctions?
No, thank you.
No, thank you.
Yeah, ask.
No, I think someone's mic was on.
Welcome. Okay, let me turn it off. It's off. Sure. So that would be all about the epithelial junctions. These are all the topics which you need to study. We will just study them later in the sections. Okay. Sorry about that. Okay. So before starting dermatology, you first need to know some terms which we are gonna use in the later chapter. Okay. The first one is the macule, which is kind of a hyperpigmented patch you can see. Okay, it is always a flat lesion. Okay, and the size is always less than 1 centimeter. As you can see on the lips of the patient, you're having this hyperpigmented patch-like thing. Okay, this is known as the macule. Then you have the patch, which is a hyperpigmented macule, this macule of more than 1 centimeter of size. Okay, it could be a birthmark, which most of us have sometimes, right? Then we have the papules. It is a elevated or the raised lesion. Okay, any elevated or the raised lesion who is having a size less than 1 centimeter, you call it a papule. Okay, and a raised lesion of size more than 3 centimeter, you call it a plaque. Okay, and the plaques could be found in the psoriasis, as you guys remember. Okay, so as you can see, these are all the plaques. Okay, then you have the vesicles, which is a kind of papule which is filled with the fluid. Okay, and this papule which is filled with the fluid, you call it a vesicle, right? And the size again is less than 1 centimeter. Okay, you will get the chicken pox, right? You will get the shingles, you will get the sorry, yeah, you will get the chicken pox and you will get the shingles because of reactivation. And in both these disorders, you will get the vesicular kind of rash, right? So this vesicular rash is for the vesicle fill, this papule filled with the vesicle. Then you have the bulla, which is a large fluid-filled vesicle of size less than 1 centimeter. So whenever you encounter a patient who is having these fluid-filled vesicles of size more than 1 centimeter, that means they're talking about the bulla, right? Then you have the pustule, which is a papule filled with the pus. Instead of this water, instead of the fluid, okay, this raised lesion is filled with the pus, right? And it is known as the pustule. Then you have the wheeling, which is seen in the urticaria, right? And yeah, you will have the scales then, and the scales in which you have a plaque, and over that plaque, some parallel lines are formed, right? And these parallel lines are known as the the scales, right? Very important. Okay, so you can see these wheels, you can see the these scales, okay, in the psoriasis, in the eczema, and in the squamous cell carcinoma, okay, in the main exam. So yeah, so that will be about the scales. You'll get this in the squamous cell carcinoma, you'll get in the psoriasis, you'll get in the eczema also. So whenever you get a plaque-like thing, okay, and over that plaque you're having these parallel lines, that means in the exam they're talking about the scales, right? Then you have the crust, okay, which is kind of a triaxuate, okay, and it will be seen in the impetigo, right? The honeycrust lesions that you see on the impetigo, these are all due to the triaxituates, right? So any doubt on these terms?
No, thank you.
No.
Okay, then some microscopic terms, which will be very much helpful if you guys remember them on the biopsy of the patient. The first one is the hyperkeratosis. Okay, that means and the hyperproliferation of the stratum corneum, which is the outermost layer of the keratin, right? You will have the skin thickening because of that, a kind of plaque formation because of that, right? This condition is seen in the psoriasis and in the callus. Okay, and the callus generally involved the skin of the palms and the soles. Whenever you have a skin thickening over the palms or the soles, okay, and on the biopsy, you're having this the proliferation of the stratum corneum, that means you're talking about the hyperkeratosis, right, because of thickening. Then you have the parakeratosis we have discussed. In this, you're having the nucleus or the nuclei in the stratum corneum, because the stratum corneum is kind of a dead cell layer. It devoid of any kind of this nucleus. Okay, if you have the nucleus, which means the immature cells are present. Okay, and these are generally seen in the psoriasis and the actinic keratosis. Please remember these examples, that are all the examples that you must remember. Okay, only those examples for these conditions you must remember for the step one, right? So keep memorizing them again and again and again. Okay, then you have the hypergranulosis, in which you're having a thickening of the stratum granulosum. Okay, and this hypergranulosis is a very specific feature for the lichen planus. Okay, it is a very classical feature for the lichen planus, very important. The hypergranulosis. Then you have the spongiosis, okay, which is kind of a fluid accumulation in the in the intercellular spaces of the epidermis. Okay, and this condition is generally seen in the contact dermatitis. Very important. This condition is seen in the contact dermatitis. Then you have the acantholysis, okay, which is a suppression of the epidermal cells. Okay, when the epidermal cells kind of become very much, what I must say, okay, so when the suppression will occur, that will lead to the acantholysis. And these conditions are generally seen in the pemphigus vulgaris. And if you guys remember from the last page, the pemphigus, oh, sorry, yeah, the pemphigus vulgaris will cause the antibodies against the desmoid agents, right? Very important. Okay, and then you have the acanthosis. Okay, and in the acanthosis, you're having the proliferation of every layer of the skin. Okay, see, in case of hyperkeratosis, you're having just a proliferation of the stratum corneum. But in case of acanthosis, you will be having a hyperplasia of the of the corneum, of the lucidum, spinosum, gangulosum, basilae, every layer of the skin. You will get the proliferation, right? So that's a huge difference between the in the acanthosis and the hyperkeratosis. And these acanthosis will be seen in the condition known as the acanthosis, acanthosis nigricans, and the psoriasis. You can also get the acanthosis in case of this chronic contact dermatitis. Right. These are all the symptoms of the acanthosis. Any doubt?
No, thank you.
Okay, now comes the pigmented skin disorders. The first one is the albinism. Okay, and you guys already know that in case of albinism, you will be having a decreased melanin production because of the deficiency of the enzyme known as tyrosinase. Right? Remember the tyrosinase, it converts which substrate into what form?
Tyrosine to dopaquinone.
Are you sure? It's the tyrosine hydroxylase which converts the tyrosine into dopa.
I'm saying conversion of tyrosine to dopaquinone.
Yeah, the conversion of the
Tyrosine to
dopa.
dopa.
Yeah, the conversion of tyrosine, the conversion of dopa into the melanin. Okay, this would be prevented with the help of this. Sorry, this condition will be promoted with the help of this enzyme known as tyrosinase. And if the tyrosinase is not there, then the production of the melanin or the conversion of all this dopa into the melanin will be decreased, right?
Yeah, yeah.
And that's how you can get the albinism. Okay, patients, they will have the blonde hair, they will have the blue eyes, and they will have this white skin or a very pale skin. Okay, and because the melanin is not there, that means the skin is very much prone for the cancer. Okay, they have a very high risk of skin cancer, and that's why they need to avoid, the unnecessary exposure to the sunlight. Okay, very important. Then you have the melasma, okay, which is happens because of the increase in the melanin synthesis, and it generally happens in the pregnancy, and that's why it is known as the mass of the pregnancy. Very important. And yeah, so it is more common in the woman with the darker these complexions. Then you have the vitiligo, okay, in which you're having the autoimmune destruction of the melanocytes at some localized areas, and that's why you will get the localized hypopigmentation of certain areas of the of your body, right? And yeah, so it would be these irregular patches, and if anyone remember what a patch is,
Flat
than
lesion of more than
more
1 centimeter.
than
yeah, exactly, a flat lesion of less than 1 centimeter, right? This is the patch that you will get on the vitiligo, right? You will have a complete depigmentation, of course, and yeah.
Dr. Patch is more than 1 centimeter, I think.
more than one.
Macule is less than one
Oh yeah,
centimeter.
sorry. Yeah,
Mm.
sorry about that. The macule is less than one, but the patch is more than one. Yeah, sorry about that. So a lesion which is kind of a hypopigmented and it is more than 1 centimeter, and the lesion is hyperpigmented because of the loss of melanocytes, right? Because of the autoimmune destruction of the melanocytes. Okay, you will get this condition. And also for
No, thank you.
No, thank you.
okay. Now comes a seborrheic dermatitis. Okay. Now, as the name suggests, it is an inflammatory condition of the skin first, and it is the seborrheic. That means you will having a rich sebum in the skin. Okay. So this condition will be very erythematous, and it will present with the erythematous well-demarcated plaques. Okay, and they have a very greasy yellow scales. Why greasy? Because of presence of the sebum, right? And that's why the name seborrheic dermatitis, right? It is common in both the infants as well as the adults. This condition could be associated with the Parkinson's disease. Okay, and yeah, it could be also associated with the malassezia furfur. Okay, and yeah, that would be it about the seborrheic dermatitis. Nothing but just a very well demarcated, okay, kind of erythematous, or I must say the reddish plaques you will see, right? And these plaques are very greasy to touch because of the presence of sebum, right? Very important. And yeah, that would be all about the seborrheic dermatitis. Any doubt on that part?
No, thank you.
Okay, now comes the common skin disorders. First, you have the acne, okay, which is because of the blockage in the duct, okay, which is producing your sweat, which is producing your sebum, right? And please note, it generally happens in the pilosebaceous unit. Because of a blockage in the pilosebaceous unit, all these secretions will start building up, okay, before the before this blockage, the bacteria will proliferate and will cause the infection and the inflammation there, right? And that can cause the acne. Okay, so please note the bacterial agents which are responsible for the acne. These are the propionibacterium acne. Okay, very important. The propionibacterium acne. Okay, it is responsible for the acne in your body, right? And yeah, they're also associated with the comedones. Very important. Treatment include retinoids, the benzoyl peroxide, as well as the antibiotics. Okay, antibiotics to control the bacterial overgrowth. Antibiotics. Okay, and yeah, that would be all about the acne. So in all the conditions, okay, in which you're having a follicular hyperplasia, this follicular hyperplasia can also block the duct, and as a result, you can get the acne along with that, right? This is also a very important thing. And any condition which decreases the drainage of the sebum or increases the production of the sebum, okay, they can cause this scenario. Okay, this is also very important. Any condition which decreases the excretion of all this sebum and increase the production of the sebum, okay, you need to be very careful. Any doubt?
No.
No, thank you.
Okay. Then you have the atopic dermatitis, which is a type 4 hypersensitivity reaction, right? Sorry, it was a contact dermatitis, not the atopic dermatitis. I'm sorry about that. The atopic dermatitis is a type 1 hypersensitivity reaction. It involves the eosinophils. Very important, right? And it is only seen in those individuals who are having any history of the previous type 1 hypersensitivity reaction, like the asthma or any food allergy, right? Or any kind of allergy, I must say. Okay. So if the patient is having a history of this kind of a rash, okay, along with a history of the, all this asthma or maybe a food allergy or any kind of allergy, that means we're talking about the atopic dermatitis. Very important, right? This condition mainly affects the flexure surface of the skin, okay, and it is associated with the other disorders like the asthma, allergy, rhinitis, food allergies, other things. You will be having a high level of this IgE, okay, and this condition is all due to a mutation in the flagging gene. Very important. It's all due to a mutation in the flagging gene, and as a result, the protective mechanism for the skin is now lost. Okay, and all the bacterias, all the viruses, all these inflammatory agents, they can cause the fibrosis and kind of atrophy there, right? A kind of rash there. Okay, so all this is because of the flagrant gene. As a result of this barrier protection of the skin is now lost. Okay, all these bacteria, these allergens, they can stimulate your skin and they can cause the inflammation there. Okay, that's about the atopic dermatitis. Please note the location of the rash. It is on the flexor surfaces. That okay. So any doubt?
No, thank you.
Okay. So now you have the allergic contact dermatitis, and please note that it is a type 4 hypersensitivity reaction, which means whenever you have an encounter with any allergen, okay, after the encounter, you will develop the rash only after 3 days of the exposure. Whenever you exposed with the allergen, you will get the rash only after the 4 days. So it would be a patient, okay, who go on a camping, or or they might be a forest officer, okay, and the part where the skin is now exposed, okay, they can get into contact with some kind of allergen, and now the patient is having the symptoms, and they will tell you that the patient is having the symptoms for like uh, more than a week, okay, or might be something like that condition. Okay, so basically a history of allergen, and only after 3 to 4 days you're having this all this rash kind of thing on the skin, right? So this is the important thing about the allergic contact dermatitis. Okay, and please note any kind of substance can cause the allergy. Okay, and the rash will appears, will takes up the shape of of that allergen. Okay, so maybe in case of any belt use, you can get a rectangular type of rash, right? Similar conditions like that, and they will ask you what is the primary thing that happens in case of this allergic contact dermatitis. So this will be the activation of the Langerhans cell cystocytes. Okay, it is the activation of the Langerhans cell cystocytes. Now these Langerhans cystocytes, they will stimulate. Okay, they will check. Okay, and then they will cause the responses. So just one thing, remember, after the exposure to the allergen, you will get the symptoms only after 3 to 4 days. That would be about the allergic conjunctivitis. Any doubt?
No, thank you.
No, thank you.
Okay. Then comes the melanocytic nevus, okay, which is a very benign condition. Okay, you're having a mole in these conditions. Okay, and what would you call a mole in the, you know, in the terms we've discussed for for a, for this derma section? We have discussed some terms. What you can call a mole?
Nevus.
Yeah, nevus, of course, but in these terms we have discussed about all this derma section. Anyone?
Papule?
Yeah, it would be a papule. Okay, please note that condition. It would be a papule. So this melanocytic nevus, it will present you with a papule only, right? And please note that it is a most commonly benign condition. Okay, rarely it can transforms to the cancer, right? That means a negligible cases can transform into a cancer, but most of the time it is the benign condition, a pure benign condition. Okay, and sure. So you'll be having some kind of a neoplasm, a benign neoplasm, which is consist of the round uniform blue cells. Okay, and these are the melanocyte cells. Okay, and all this nevus will have a very sharp, well demarcated border. Okay, and a homogeneous surface with a same color. Okay, and why you need to emphasize on this point, that the same color lesions would be there. Okay, and yeah, does
To
anyone?
differentiate it from melanoma.
Exactly, to differentiate it with the melanoma, because in case of melanoma you'll be having a very abnormal type of connection, right? And you'll be having a very abnormal high mitotic activities would be there. In that case, you'll be having a very abnormal type of color combinations, like blue, the blue would be there, the black would be there, the red would be there. Okay, so a kind of very much abnormal color combinations would be there, irregular borders would be there, right? These are the very hallmark features of the melanoma, versus in case of this nevus, okay, you'll be having a very homogeneous kind of tissue, right, with a very well demarcated borders. Okay, now based on the types, you can have a three type of melanocytic nevus. One is the junctional, second is the compound, and third is the intradermal. Now in case of junctional nevus, you'll be having these neoplastic cells, right, present at the basal surface layer, right? You will all these nevus cells, or this the tumor cells, they will be present at the junction, right, of the epidermis and the dermis, right, or I can say the basal surface of the epithelium, right? And still the cells does not, okay, included the dermis now, right? Only the superficial layers, okay, at the basal cell layer, or I must say just before the dermis, these cells are present. Then you have the compound, and yeah, how does uh, this nevus will appear, right? So it will be a flat macule only. Okay, a macule is having a size more than or less than 1 centimeter.
Less than.
Less than.
Yeah, exactly, less than 1 centimeter. Okay, so what thing you will get is a flat macule. Okay, and yeah, that's would be all. Then you have the compound nevus, okay, in which you're having this the presence of these neural cells, okay, or the neoplastic cells, I must say. Okay, in case of compound nevus, you'll be having the presence of all these neoplastic cells in the at the junction or in the dermis also. Okay, so all these cells are present on the junction of the dermis and the epidermis, which means the basal layer. Some of the cells are also present in the dermis part also, right? So a basal surface of the epithelium will be extending into the dermis, that you can see on the compound nevus. Okay, and then you have the intradermal nevus, which is the last stage, in which you're having a shifting of all this nevus, or the neoplastic cells into the subepithelial region or the dermal regions, right? So it will be a dermal nevus. Okay. And here are features of the compound nevus. Sorry, we have failed to discuss the features of the compound nevus. Okay, it will be a raised papule. See, the more superficial location of the neoplastic cells you have, the more flat is the lesion. Okay, like in case of the junctional nevus, you'll be having a presence of all these neoplastic cells in the epidermis at the junction, right? And the nevus is very much kind of flat macule in case of junctional nevus, right? In case of compound nevus, okay, all these cells will be extending into the dermis. So the cells will present both in the dermis as well as in the epidermis. Okay, and now this macule is now raised. Okay, and the raised macule is known as the papule. Okay, you need papule for that. Then you have the intradermal nevus. In this condition, all the neoplastic cells are present only in the dermis, not in the epidermis. Okay, and dermal lesion and the dermal nevus. Just give me a second about that. Yeah, so in case of intradermal nevus, you will be having a presence of neoplastic cells within the dermis only, no in the epidermis. And please note that all of these cells will also loses the capacity to form the melanin, right? And as a result, you will be having a hypopigmentation because of that overgrowth, right? Or that papule. Okay, and yeah, that would be all about the melanocytic levers. Okay, so the deeper the cells are, okay, more sorry, less flat the lesion would be, right? In case of intradermal, you'll be having a loss of melanin, so it would be a pale uh, supply. Okay, and about that, the patient can also have the papules as well as a perpendicular kind of rash. So any doubt on the melanocytic nevus?
No, thank you.
No.
Then you have the pseudofollicular barbe, and the only thing that you need to remember that the patient will be having a rash, okay, a very abnormal type of rash on the shaving area. Okay, that's the only thing you need to know, that the patient will be having a rash at the shaving area, which means, you know, just after a shave, the patient uses a soap or some water to clean it. Okay, so hyperpigmented papules would be there very importantly. And please note that these papules are very much hard. You can say the form. Okay, and please note that all these are in the shaving areas. The only thing that you need to remember, the rash in the shaving areas, you will always think about the pseudofolliculitis barbae, right? They are also known as the razor bumps, and they are generally seen in the African American males. African American males are most commonly affected because of this disorder, because of the this folliculitis barbae. Any doubt?
No, thank you.
No.
Just give me a second. Sure. So now comes the psoriasis, and as we have discussed in the previous pages also, what features you can expect on the psoriasis. You can see the
Correct.
pustule can be there, you can see the plaque could be there, right? On the biopsy, you can see the hyperkeratosis, you can see the parakeratosis, you can see the this acanthosis also, right? And that causes a thickening on the plaque formation, this acanthosis at the hyperkeratosis, right? So with these things in mind, let's discuss the psoriasis. So this could be the papules, this could be the plaques, okay? And please note the plaques are most commonly the erythematous or the radish like plaques, reddish plaques with a silvery scaling. As you can see, you will be having a rash with a silvery scaling over the rash. And these are a very hallmark feature or a very characteristic feature of the psoriasis. Okay, very important. And these conditions are generally affects mostly the elbows and the knees, which means the extensor locations are very much important sites for the psoriasis. Okay, and these locations are under very much friction with the surfaces, like the table, like the wall, like the chair. Okay, so these locations are very much under the friction with the surfaces, and that's why this condition mostly affect only those areas of the skin which are under the friction, like the elbows, like the knees, like the other extensor surfaces. Okay, so whenever you get the friction, you can get the psoriasis. Okay, on the biopsy, you can get the acanthosis. Okay, which means the epidermal hyperplasia. You can get the parakeratotic scaling. What does the parakeratosis means?
Presence of nuclei in the upper layer.
Exactly,
Nuclear.
right? You will get the scaling. You will get the nuclei remaining in the stratum corneum. You will also get the micro abscesses because of dilation of the blood vessels in the dermal regions. Right, because of the blood vessel dilation, you can also get the bleeding with a very minor trauma. If you have this kind of plaques on the body and you somehow get rubbed with any kind of surface, you can get some micro bleedings there, right? A pinpoint bleeding, right? So this is the Auspit sign, which is a pinpoint bleeding. It is because of a dilation of the blood vessels. Okay, you will also get the collection of all these antibodies and the neutrophils. Okay, in the layer, so we get the Monroe's microabscesses also. Okay, because of deposition of the neutrophils in the papillae, right? Just give me a second again. Sure. So if you guys go back, if you look on the stratum basilis, okay, you are having these kind of tips, okay, these kind of structures, okay, in the dermis, and these are known as the radiages. These are known as the radiages. You will be having a very elongated radiages in case of psoriasis, okay, and the deposition of the neutrophils in these radiages, okay, this causes the micro abscesses, because abscess is nothing but just a collection of neutrophils, right, that are causing the what kind of necrosis? Neutrophils.
What
What kind
kind
of
of
necrosis? Necrosis you will get in the abscess.
liquefaction?
Exactly. Okay. So that's when some micro abscesses, those micro abscesses. Okay. So that's a psoriasis. You will get the Monroe microabscesses because of deposition of the neutrophils there. You will be having a dilation of the blood vessels in the dermal region. And as a result, whenever you get any friction, whenever you get any rub, you will get the micro bleedings there, right? And these are a very, very important, a very specific sign for the psoriasis. Steven will, mention this every time. Then it will be a patient who is having some kind of a rash. Okay, and whenever they try to scratch the rash, or just automatically the patient will have this micro bleedings in this rash, right? So they're referring to the Auspit sign because of the expansion of the dermal papillae, right? And the nail pitting will be the this complications. Psoriatic arthritis will be the complications, and the arthritis mutilans will be the complications of the psoriasis, right? So yeah, that would be all. And please note it is CD4 mediated. Okay, it is CD4 cell mediated. So any doubt on the psoriasis?
No, thank you.
Then you have the rosacea, which is similar to that of acne, but unlike the acne, rosacea, they do not have any comedones. Okay. And second important hint that you need to remember, okay, is the facial flushing after the alcohol. They will always tell you that the patient do not uses the alcohol because it makes her uncomfortable or something. Whenever they take the alcohol, they will get the flushing of the face, right? And this is a very important symptom of the rosacea. Along with that, patient get the erythematous papules and the pustules. Similar to that of acne, you will get the papule and pustule there, right? And yeah, So, but they do not just have any kind of chromosomes, and that's why it is not the acne, but the rosacea, right? Okay, so any doubt?
No.
Okay. I think we should take a short break, right?
Yes.
And then we will study the seborrheic keratosis. Okay.
Yes.
Okay.
Thank you.
I'm sorry about that.
Recording.
Okay, you will be having a hyperplasia of the epidermis, which means the acanthosis. You'll be having the hyperkeratosis also, which means the proliferation of the keratinocytes. You will be having a coilocytes because that is a hallmark feature of the human papilloma virus. Whenever you have a infection with the human papilloma virus, the coilocytes with the is the hallmark feature of this infection. Okay, in this condition, we'll get the paranuclear cytoplasmic vacuolization in the cells. You have the cytoplasm, you have the nucleus. Around the nucleus of the cell, you'll be having a perinuclear clearing, right? Like a vacuole around the cytoplasm, right? So these are the coilocytes which are seen in the verrucase. So a cauliflower-like lesion, right, or a wart-like lesion caused by the papillomavirus. Okay, and they have the this hyperkeratosis, acanthosis would be there, right? Coilocytic change would be there. Very important. And does anyone know what strains of the human papillomavirus, this HPV, this virus can cause the verrucase?
6 and 7.
Exactly, up to the 6 and 7, right? And what strains can cause the verrucae or the warts in the genital lesions?
1, 2.
No, not the 1 2. See, the earliest strains or the 1 to 5. Okay, I'm sorry about that. Sorry, I got misconfused. The strains up to 5, 1 to 5. Okay, they're involved in the skin warts. Okay, the strains 6 and 11, they're involved in the genital warts. Okay, and the strains after that, that means 16, 18, 32, 54. Okay, these strains can cause the this cervical intraepithelial neoplasia, right? CINs, right?
Yeah.
So later strains, they can cause a cancer, CIN. Okay, the mid strains, which means 6 and 11, they can cause the genital warts. Okay, and the strains like 1, 2, 3, 4, 5, they can cause the skin warts. Okay, do please remember these facts. Okay, about the strains. Then you have the urticaria, which is also known as the hives. Okay, it is a kind of this plaque-like condition in which you get this kind of the very reddish plaque all over the body, and it is highly pruritic condition, all because of mast cell degranulation and the release of histamine. Okay, that can cause this kind of a reddish rash. Okay, and the patient will have the pruritic wheals. Okay, that form because of the mast cell degranulations. Okay, patient will also have a dermal edema. This is also very more this important fact. You must remember. Step one will ask you this. Okay, what are the findings you can get on the skin? One of the findings will be the dermal edema. You will be having an edema in the superficial dermis. Okay, along with the lymphatic channel dilation. Okay, so this condition will, the symptoms in this disease will arise very suddenly. Okay, very spontaneously, and they also kind of resolve, very suddenly after the hours. Okay, within hours, the symptoms will be resolved. Patient will get this kind of erythematous rash, and it is highly pruritic. Very important. Sometimes you can also get the central clearance or the paleness in the urticarias, right? And yeah, angioedema would be there, and that can cause the dermal edema, right? So this is the urticaria, which is a kind of erythematous plaque you will find on the skin, and it is highly pruritic, all because of the mast cell degranulation. Any doubt on the urticaria?
No, thank you.
Okay, so that would be all the common skin disorders. Okay, and yeah, one more thing you need to remember for the acne, that the steroids, okay, they can cause the increased sebum production. And like I told you, any condition with which increases the sebum production or decreases the clearance of the sebum, it can cause the acne, right? So these steroids, or all these agents like the testosterones, right, or any other agents, they can cause the increased sebum production, and these can cause the acne. Okay, Very important. And if you go for the reproductive section, then the FA mentioned one point about the testosterone, right? And if you have the high level of testosterone, you can get the acne. Remember?
Yeah, yeah.
And why is that? Because of the increased sebum production, right? Whenever you have an increased sebum production or decreased sebum clearance, you can have the acne. Okay. And similarly, anything which can block the drainage, okay, like any kind of follicular hyperplasia, right, that can cause the acne again. So yeah. For the psoriasis, you can use the topical corticosteroids, okay, for the as a treatment of the psoriasis. Okay, you can also use the vitamin D analogs. Right, vitamin D analogs you can also use. Okay, they basically act on the vitamin D receptors and they decreases the proliferation and increases the differentiation, right? Because in the psoriasis you're having these plaque formations, right? And it is all because of the hyperproliferation of the epithelial cells, right? So what does this vitamin D do? It will cause the inhibition of the proliferation, and it will cause the increase in the differentiation of the cells, right? So that the psoriasis could be prevented. Similar thing could be done by the vitamin A also, right? So vitamin A can also prevent the psoriasis by inhibiting the hyperproliferation and by stimulating the differentiation, right? And that is the important thing that you want in psoriasis for a treatment, right?
Yeah.
So do remember this fact also. This is about the melanocytic nevus, okay, in which you're having a benign neoplastic proliferation of these melanocytes, right? You will be having a round uniform cells, which are the hallmark features of the melanocytes, right? And a very sharp demarcated border would be there. It would be a homogeneous lesion, okay, not a heterogeneous type. So, that color will be very much uniform, okay, and the borders are very well demarcated, right? You have three forms: the junction nevus, the compound nevus, and the dermal nevus, interdermal nevus, right? In the junction nevus, you'll be having these neoplastic cells within the at the junction of the dermis and the epidermis, right? In the compound nevus, some of the neoplastic cells will be entering your this dermal layer, and some of the cells are present in the junction, right? So that's why the name compound. And then in the interdermis nevus, you would be having all these neoplastic cells within the dermis, right? The junction nevus will appear as a flat macule. Okay, the compound nevus is somewhat raised and it is appear as the raised papule. The interdermal nevus is appear as the papule, right? Again, as a papule or a very pedunculated lesion. Okay, you'll be having a pedunculated lesion, right? And that's all. Okay, this junction nevus is very much hyperpigmented. Compound nevus is kind of brown or a tan colored. Okay, and the interdermal nevus, it is devoid of any color, right? It is of the skin color only, or sometimes a very mildly hyperpigmented or a tan colored, right? So as the cells go deep, okay, the lesions will become very much kind of raised, okay, and the color of the lesion is also decreased, right? That's the features you will get in the nevus. Okay, then comes the vascular tumors of the skin. Okay, and first is the angiosarcoma. If you guys remember from the immunology lectures, we have discussed if you're having this lymphedema thing, okay, then this lymphedema can cause the angiosarcoma. Remember
Yeah.
from the immunology, we've discussed that if the patient is having any kind of lymphedema, okay, then as a complication of the lymphedema, patient can get the angiosarcoma, which is the blood vessel malignancy, of course. Okay, and this thing generally happens whenever you want to, uh, like any condition you can cause a lymphedema, and but most oftenly you need to remember about the breast cancer, okay, while doing the mastectomy, okay, and while doing the lymph node dissection, okay, you can sometimes got the blockage in the lymphatic flow pathway, and as a result you will get the lymphedema because of that. And because of this chronic lymphedema, patient can get the angiosarcoma. So most of the times in the step one, it is going to be a case of a patient who is having a breast cancer, and after the treatment of the breast cancer, the patient started having this kind of a heaviness in one arm, okay, and a swelling in one arm, right? And now the patient is having this angiosarcoma. Okay, very important. You can also get the hepatic angiosarcoma if you guys remember the causative agents, the vinyl chloride and the arsenic, right? You can get the hepatic angiosarcoma because of that. And these tumors are very much aggressive, of course, right? So yeah, that's about the angiosarcoma. It is a malignant endothelial proliferation. Chronic lymphedema is a risk factor, important one as the breast areas, right? So how does this patient with angiosarcoma present you? They will present you, with some kind of a multiple violaceous nodules, right? And these are very hard nodules. Okay. So a patient with a chronic history of the lymphedema or a patient with a previous history of any breast cancer surgery, now having these violaceous nodules, multiple violaceous nodules on the skin, that means they're talking about the angiosarcoma. Is that okay?
Yes.
Okay, then comes the bacillary angiomatosis. We have discussed that already. Okay, it is seen in the patients having infection with the Bartonella Hansleigh, right? And it is seen in the HIV patients. On the biopsy, what you can get is the neutrophil infiltration, right? And how these lesions will appear you. They will appear as the violaceous nodules again, right? Violaceous, reddish, or brownish kind of lesions on the skin. They will appear because of presence of the blood vessels and the blood, right? They will appear as a bluish. They will appear as the brownish lesions, right? Then you have the cherry hemangioma, okay, and this is seen in the middle adult, okay, middle age adult, okay, and it is also a capillary hemangioma. A benign tumor is that, okay, it is. And please note with the age, okay, this tumor expands and increase in the size as well as in the frequency, okay. Similar to the cherry hemangioma, you also have the strawberry hemangioma. This strawberry hemangioma is present in the children, okay, in a very newborn child it could be present, okay. With initially with the age, this tumor grows and increase in the size, right? But after 5 to 8 years of age, this tumor completely regress, right? So in a very initial stages, the tumor will expand, okay. But after 5 to 8 years, the tumor will regress spontaneously. And the size of this strawberry hemangioma is very much large, okay. But this cherry hemangioma is very much small, right? And the frequency and the size of this tumor increases with the age. It is seen in the adults. The strawberry hemangioma seen in the children, right? As you can see here, this is the strawberry hemangioma, right? And this is the cherry hemangioma. Okay, any doubt on the strawberry hemangioma or the cherry hemangioma?
No, thank you.
Okay, and yeah, then you have the glomus tumor. Very important about the glomus tumor. Glomus bodies, first you need to remember the glomus bodies are kind of a, these are the modifications of the smooth muscle cells, right? And these bodies actually maintain the thermoregulatory mechanism in the fingertips, right? In the nails. Okay, so these are the thermoregulatory bodies, and these are the modification of the smooth muscle cells. Okay, and once you get the tumor, this tumor generally involves the nails. Okay, as you can see on uh, this picture also, these are having some kind of lesions within the nails, and these are the glomus tumors, a very specific location for a tumor. Okay, only two tumors can involve the nails. One is the glomus tumor and second is the melanoma, right? Very important. So these tumors are found under the fingernails, and these are the tumors from the modified smooth muscles known as the glomus body. Okay, it will appear as a bluish kind of lesion under the nail beds, okay, under the fingernails. And please remember, it is a very painful condition. Okay, then you have the Kaposi sarcoma, which will appear as the violaceous nodules or a reddish brownish nodules on the skin. And not just the skin, this condition can also affect your organs, right? As well as the GI tracts. So you can get a violaceous nodules in the GI tract also that can bleed and can cause the bleeding stools, right? And these conditions are also found in the HIV patients only. And on the biopsy, what you can get is the lymphocytes. Okay, it can mimic just like the bacillary angiomatosis, but in bacillary angiomatosis, you're having the presence of neutrophils. In case of Kaposi sarcoma, you're having the presence of lymphocytes. And this condition is caused by the HHV8. Okay, very important. Then you have the pyogenic granuloma. Okay, and this is seen in the pregnancy mainly. Okay, and please note that this kind of a lesion is very much ulcerative type of lesion. Okay, whenever you encounter a patient, they will tell you that they are having this kind of ulcerated lesion that bleed on touch. Okay, very important, a lesion that bleed on touch, because of course it is a blood vessel tumor. Whenever you touch it, whenever you try to scratch it, the blood vessels will get ruptured and that can cause the bleeding, right? So all these tumors you see, they all will bleed with the touch, right? Not just this much tumor. Okay, so any doubt on this page so far?
No, thank you.
No, thank you.
Okay. Then you have the bacterial infections. Okay. First, you have the impetigo. We have discussed that already in the microbiology section. Okay. And but please note that it is a very superficial skin infections. Okay, very important. And it is caused by the Staphylococcus aureus and the Streptococcus pyogenes. Okay, you knew these agents already, and they will appear as the honey crusting lesions. Okay, and as you can see, they will appear as this kind of a honey crusted lesions. And does anyone know why the patients are having the honey crusted lesions in case of Staphylococcus aureus impetigo? Why this honey color?
Yellow colored pigment in Staph aureus.
Exactly, because of the yellow colored pigment in the Staph aureus. That's why the impetigo, which is caused by the Staphylococcus aureus, it is always honey colored crustings, right? Because of the presence of these pigments. Okay, very important. Okay, without honey color, you will get this Streptococcus pyogenes. With the honey color, you will get the Staphylococcus aureus. Okay, you have two type of impetigo. One is the bullous and one is the non-bullous. Non-bullous is mostly caused by the Streptococcus pyogenes, but can also majorly caused by the Staphylococcus aureus too, right? But the bullous impetigo, it is only caused by the Staphylococcus aureus. Okay, very important. So the bullous impetigo, it is only caused by the Staphylococcus aureus. Okay, they will be having a this honey crust as well as a bulla formation all over the skin. You will be having a very large fluid-filled vesicles all over the skins, right? Along with the honey crusting lesions, right? These are the features of the bullous impetigo. Then you have the erysipelas, okay, erysipelas, and these condition also affects your lymphatics, right? The condition will also infect the lymphatics, okay, and they will appear as a very well demarcated raised lesion, okay, between the infected and the normal skin. As you can see, this is the normal skin, this is the infected skin. Patient will have a very well demarcated border and a very raised lesion, right? And this raised lesion, it also affects the lymphatics of the underlying skin, right? So you will get the edema, a very kind of very much severe edema you will get, as you can see, right? So the erysipelas will present you a very well raised demarcation between the infected and the normal skin. It is caused by the Streptococcus pyogenes, okay? And this infection involves the superficial skin as well as the lymphatics of the superficial skin. All right. Then you have the cellulitis, and cellulitis will present you just like a deep vein thrombosis. Okay, both of them have a very clinical presentation of very similar to them. It is a right. Both of them will have this pain, tenderness, redness, swelling over that area. Right. Whenever you palpate, patient will have a pain. Right. But the only thing that differentiates between the cellulitis and a normal deep vein thrombosis is the presence of fever. Whenever you have a fever, okay, after a fever, you're having this pain, tenderness, redness, swelling over that area. That means the patient is having a cellulitis. If the fever is not there, that means the patient is having a deep vein thrombosis, right? It is most commonly caused by the Streptococcus pyogenes, and the Streptococcus aureus generally happens after a trauma, okay? And unlike the erysipelas, the cellulitis, it do not have any well demarcated borders, okay? As you can see, this is a cellulitis. Okay, a very a very swollen region would be there. Okay, a right metas area would be there, right? And a very painful condition it is, generally caused by a very minor through which these bacteria can gain access to your skin, and as a result they can cause the cellulitis there, right? Then you have the abscess, which is nothing but just the neutrophils come to the this infection place, and they will cause a liquefative necrosis there. Okay, it will fill with some kind of a fluid, okay, which contains the necrotic material, and this is known as the abscess. Okay, it is the collection of the pus, you can say. Okay, and the most common offending organism which can cause the abscess of the skin is the Staphylococcus aureus. Okay, very important. Then you have the necrotizing fasciitis. Okay, it is a kind of a severe complication, you can say, of the cellulitis. Okay, once the patient is having a cellulitis, if the bacteria go further more depth to your skin, okay, then they can cause the infection or the inflammation of the fascia also, that covers your muscles, right, or the muscle groups, right? And that can cause the necrotizing fasciitis. In this, apart from having symptoms like the cellulitis, patient will also have the septic shock. So whenever you encounter a patient who is having a pain, redness, tenderness, swelling over an area, apart from that, patient is also having a sepsis, which means a high heart rate and a low BP. That means it is a case of necrotizing fasciitis. And as the FH mentioned, that the pain may be out of the proportion of the exam finding. The patient will be having an extremely severe pain, but the findings are like the cellulitis only. And when you ask the patient to rate the pain, they generally rate the pain at level of 9 out of 10 or 10 out of 10 even, right? So a very severe pain is there. Okay, and you can also get the bullous and the skin necrosis. Okay, and yeah, that would be all. And because these bacteria, they will feed on your on your glucose in the body, and they will release a CO2 after that, right? So you can even see the formation of these bullous because of this CO2 producing bacteria, right? So you will have the subcutaneous crepitus. Just like if you guys remember one pathogen from the microbiology in which you get the subcutaneous crepitus and all these similar findings.
Clostridium
Perfringens,
perfringens, yeah.
right? In the perfringens, because of a minor trauma, the bacteria will be inoculate and they will cause the myonecrosis, right?
Yeah.
Similar to that, you'll be having a necrosis here, the skin necrosis that can release the oxygen also, and that can cause a subcutaneous crepitus. On the X-ray, you can see the gases formation in the subcutaneous tissue. The patient will be having a symptoms just like the cellulitis, but they're also having the sepsis in them, right? So a cellulitis with the sepsis, think about the necrotizing fasciitis. Is that okay?
Yes.
Then you have the Staphylococcus aureus scalded skin syndrome. Okay, and it is a exotoxin mediated syndrome. Okay, you have the exfoliative exotoxin. Okay, which will destroy the these attachment of the keratinocytes with the stratum granulosum. And does anyone remember what kind of junctions attaches these cells?
Gap junction.
No, not the gap junctions are kind of connecting the cells, help the cells in contacting with each other, right? Gap junctions are for the transmission of this information,
Yeah. Could
right?
you please repeat one more?
These are what kind of cell junctions, okay, are keeping these cells attached to each other, adhere to each other.
Desmosomes.
Exactly, the desmosomes, right? So what happens is exotoxin, okay, it will be active against the desmosomes and it will destroy that desmosomes between the stratum granulosum, right? And as a result, the detachment of the stratum granulosum will happen, and that can cause the Staphylococcus scaled skin syndrome. Because this syndrome is not affecting your stratum basal, which is basically your stem cell layer, right? So after the infection is over, patient will have a complete regeneration of all these lesions, right? So no rash will be found, after the infection is over. Patient do not have any kind of scar. A complete regeneration will occur, right? It is a very important thing. And what you will find is a positive Nikolsky sign. okay, which is a sludging of the upper layer of the epithelium, okay, with a very slight uh, pull of the skin, okay, very important. Whenever you manually stroke the skin, with a slight stroke, you will have the sludging of the skin, okay, and this is the positive Nikolsky sign, very important. So epidermis will come off very easily with a gentle pressure, okay, that you will see in the Staphylococcus aureus skeletal skin syndrome. As you can see here, this is how it looks, okay. If you gently press over these areas, this skin will be sludged off from that area, and this shows the positive Nikolsky sign. And when the infection is over, patient will get the complete regeneration of the skin with no scar, right? But this condition is again very much painful, okay, and because it is a baby, so they cannot speak properly, so they will just cry, okay. Patient will have a persistent cry, persistent irritation because of the pain, right? And the baby will become very much irritable, right? Yeah. So any doubt up to these bacterial infections of the skin?
No, thank you.
Just remember what layers of the skin these all bacteria, all these disorders are affecting, right? How to differentiate between these different disorders, right? And most of them are only caused by the aureus or the pyogens. Then you have the viral infections. One is the herpes virus infection, and you guys already know that in case whenever I encounter a case of herpes virus, step one will always give me a vesicular kind of rash. Okay, so herpes virus are HSV1 and HSV2. Okay, and they can cause the vesicular rash anywhere on the skin. Okay, you will get the herpes labialis, okay, which is a vascular rash on the lips. You will get the herpes genitalis, which is a vascular rash on the genitals. You will get the herpetic whitlow, okay, which is found on the finger of the patient, right? As you can see, this is the herpetic whitlow. You will found on the fingers. Then comes the molluscum contagiosum, which is an umbilicated warts. What you will get is a wart-like lesion, a pedunculated region with a central indentation like that. Okay, this is the molluscum contagiosum. It was caused by the pox virus. Okay, very important. Then you have the varicella zoster virus infection, which is chickenpox, and you already know the feature of the chickenpox. It would be a vascular rash, and all the vesicles are in a different stage of healing. Okay, some are still the papules, some are healing, some are the vesicles, right? So all of the lesions are in the different stages, right? This is what you get from the varicella zoster virus. You will get the reactivation syndrome, and you call it the shingles. And the feature of the shingle is the first is the involvement of a dermatomal region only, and second, all the vesicles are in the same stage of healing. If all the vesicles, if either all the lesions could be, the plaques, all the lesions could be the vesicles, or all the lesions could be the healing ones, right? But all of them are in the same stage of healing. That is a very important thing for the reactivation of the varicella zoster virus. Then you have the hairy leukoplakia, okay, which is found in the Epstein-Barr virus infection in the HIV patients. As you can see, they will appear as a whitish plaques on the lateral surface of the tongue. Okay, you can get the oral thrush again with the candidiasis. Okay, and they will present you with the similar symptoms, with these whitish plaques on the tongues and or on the oral surfaces. Okay, but these plaques are unscrapable, unlike the candida. The candida plaques are scrapable. Okay, but the the oral thrush are scrapable, but the hairy leukoplakia is unscrapable, and it is because of the hyperkeratosis and the hyperplasia of the this mucosa of the squamous cells, right? Very important. They will ask you what are this hair leukoplasia is actually is, right? It is the hyperkeratosis and the hyperplasia of the squamous mucosa of this epithelium of this tongue, right? Very important. And this condition is precancerous. Whenever you have this oral hairy leukoplakia, that means the patient is developing a cancer, oral cancer, or sometimes an esophageal cancer also. Very important, right? Generally seen the patients with the HIV, very important, or on the organ transplant also because of loss of lymphocyte response, right? So any doubts so far on this page? Please ask.
No, thank you.
Okay, then comes the autoimmune conditions. You have two autoimmune conditions. One is the pemphigus vulgaris and second is a bullous pemphigoids. Both of these conditions are found only in the old age patients. Okay, so it is always going to be a old age patients who have these conditions. In case of pemphigus vulgaris, you're having the antibodies against the desmosomes. In case of bullous pemphigoids, you are having the antibodies against the hemidesmosomes, right? Because you're having a detachment between the basal layer, okay, or must say the basal lamina and uh, the stratum basal of the skin, right? So this, the layer of this, because in both the conditions you're having the vesicles filled with the fluid, right? In case of bullous pemphigoid, because more layers are involved, okay, so these vesicles are kind of thick, okay, the wall of these vesicles are thick. But in case of pemphigus vulgaris, because it is a detachment the between the different, sorry, between the stratum spinosum, okay, so it contains less layer of the skin. That means less thickened wall of the vesicles, okay, and that's why these vesicles are very prone to rupture. With a slight push, with a slight friction, these vesicles will get ruptured, as you can see, okay, and you will have a positive Nikolsky sign along with that condition, right? So you will be having a fluid-filled vesicles all over the skin, and most of the vesicles are ruptured, okay, and they will have a positive Nikolsky sign. In case of bullous pemphigoid, because the vesicles are very thick-walled, okay, so they do not rupture very much easily, okay. So as you can see, all these bullas will be seen in the bullous pemphigoid, but the ruptured vesicles are seen in the pemphigus vulgaris, right? The pemphigus vulgaris is basically antibodies against the desmosomes, and the bullous pemphigoids are the antibody against the hemidesmosomes. Both the conditions are type 2 hypersensitivity reactions. Okay, what you will see on the histology is basically, sorry, not on the histology, but on the immunofluorescence, it's a reticular pattern around the epithelial cells. As you can see, the patient will have a net-like pattern when you do the immunofluorescence for the antibodies, because the antibodies will be present in the stratum spinosum. You will be having this net-like pattern of all these antibody deposition, right? In case of bullous pemphigoid, you will be having a linear deposition of the antibodies at the dermoepidermal junction, which means at the location where the this basal cell layer attaches to the dermis, right? On the basement membrane. So you will get the antibodies on the basement membrane at the dermoepidermal junction, right? This is the bullous pemphigoid. And please note, unlike the pemphigus vulgaris, this bullous pemphigoid, they do not have any in this Nikolsky sign positive. Okay, bullous pemphigoid also can involve your mucosa. Okay, and they can cause some mucosal ulcers. While the this bullous pemphigoid, they do not cause any mucosal ulcers. Okay, and these mucosal ulcers are nothing but just a vesicular rash in the mouth, in the oral cavity. You will get a vesicular kind of rash, just like the herpes you can think about, right? But a positive Nikolsky sign would be there. Okay. So, any doubt on the pemphigus vulgaris and the bullous pemphigoid?
No, thank you.
Then you have a similar condition, just like the pemphigus vulgaris or the bullous pemphigoid, but this condition is seen in the child only, in the infants, right? While these conditions, the bullous pemphigoid or the pemphigus vulgaris, they only affect the older individuals like the age 60 or 70, right? This epidermolysis bullosa, it only affects, very childs, okay? And it is an inherited disorder, okay? It is because of a mutation in the keratin gene that is responsible for the keratin, for the assembly of keratin into the filaments, right? Ultimately, you need the keratin to be in the filaments so that it could be functional, right? But due to the mutation, this keratin will no longer, be assembled into the filaments, right? And as a result, the deposition of the keratin in the interdermal regions and the dermoepidermal regions will be defective, right? And because of this condition, the patient will be having the formation of bullas and the blisters in the skin, right? And the blisters are found on the skins which are very much under the friction, right? With a slight rub, with a slight friction, patient will get the formation of these bullas. Okay, that means most of the locations are, of your soles, because the soles are in the, in a continuous contact uh, with the surface, right? So the mainly the bullas will be present on the palms and the plantar foot of the patient. Okay, oral ulcers can also be seen whenever the patient try to drink the milk or try to eat something. Because of the friction, patient can also get the ulcers there, right? And so it would be a patient, infant who just started to walk, and as soon as the patient started to walk, they're starting having these bullous kind of lesions on the plantar surface of the foot. Okay, and that's how you know the patient is having a epidermolysis bullosa. And please remember, it is a mutation in the keratin gene that is causing a defective keratin assembly into the filaments, and as a result, the deeper layer of the skin, like the uh, you know the interepidermal complex and the dermoepidermal complex, which means the these hemidesmosomes. Okay, these are affected. Okay, very important. So the lesions will completely heal and left no scarring again. Okay, and on the histology, what you will get is the intraepidermal cleavage, right? So that would be all about the epidermolysis bullosa. Any doubt?
No, thank you.
Okay. Now you have the diaperdermatitis, and if you guys remember from the Candida lectures, we have discussed that you can also get the Candida diaper rash, right? And similar kind of rash can be also present in the diaperdermatitis. Okay, whenever the patient uses a diaper and they urinate, okay, because of this chronic exposure of the skin of the patient with the urine and the stools, okay, which are trapped in the diaper, of course, the skin barrier will be breaking down, right? And as a result, more of the antigens could be presented to the cells and the patient will get the rash. Okay, so those kids who are having a history of diarrhea, they will are at a very high risk of developing this condition. Okay, the fecal bacteria will proliferate and they will cause the alkaline pH. Okay, and please note that the rash is limited to the dermal regions. Oh, sorry, the rash is limited to the diaper area only, which means in the area where the diaper is present, the patient will have the rash. And also note that this condition do not involve the skin fold versus the Candida diaper rash, which involves the skin fold also. And apart from that, the Candida diaper rash will also extend beyond the diaper borders, right? So, this Candida diaper rash will extend beyond the diaper rash, okay, beyond the diaper area, okay, and patient will also have the rash on the skin folds versus in case of a normal diaper dermatitis, the patient will be having a rash only in the diaper region without any involvement of the skin folds. Note the cause, which is because of the accumulation of the urine and the stool in the diapers, right? And as a result, the the skin barriers will be broken down. Okay, and please note the pH will be alkaline type because of the bacteria proliferation, right? So, any doubt?
No, thank you.
And please note, for the treatment, you will give the patient petroleum jelly, okay, which provides a protection to the skin barrier, right? It will protect the skin barrier from all these agents. So, a petroleum jelly will be the treatment for the dermatitis. Then you're having other blister skin disorders. One is the dermatitis herpetiformis, and if you guys remember the GI sections, right? We have discussed that this dermatitis herpetiformis is an extra GI manifestation of the celiac disease. You will be having the IgA deposits in the dermal papillae that are causing the micro abscesses, right? What will we see? We will see the pruritic papules and vesicles on the elbows of the patient. Okay, sometimes on the knees, sometimes on the buttocks also, but mainly on the elbows. So it will be a very pruritic vesicular rash on the elbows. Okay, apart from that, patient will also have a history of diarrhea, and that will make the diagnosis of the dermatitis herpetiformis. And please note, on the biopsy you will find the deposits of the IgA antibodies in the dermal papillae tips. Treatment, again, the treatment for the celiac disease, like the gluten-free diet, very much helpful, right? Then you have the ergo multiforme, okay, which is associated with the Mycoplasma pneumoniae and the herpes simplex virus, and the drugs like the sulfa drugs, beta-lactams, and the phenytoins. Patient will be having these multiple ring-like lesions. See, if you guys remember, the similar kind of rash you can see in one condition also. In the microbiology, we have discussed that condition, remember? That
Erythema
bullseye rash?
nodosum.
No, not the erythema nodosum, no. in the spirochetes we have discussed.
Oh,
Yeah. Which spirochete can cause? Borrelia burgdorferi, right?
Okay, erythema chronicum migrans.
Yeah, exactly. See, a similar kind of a rash you can get in the erythema multiforme also. But two things will help you differentiate between the two. First thing, the rash of the Borrelia is very much big and it is mostly a unilateral, a solo lesion. Okay, the rash of the erythema multiforme is very much small and it is always a multiple lesions, as you can see. A smaller multiple lesions means erythema multiforme. A large solo lesion means the rash of the Borrelia, right?
Yeah.
Erythema margins, you can see. Okay. Second thing, at the very center, okay, you will have a hyperpigmented region, as you can see. I made this figure, and as you can see on this picture also, you're having this, a very dark center, a dusky center, right? But in case of this erythema margins, right, in case of the infection with the Borrelia, you will be having a central paleness or a central clearing of this rash, right? So look at the center. If the center is hyperpigmented or dusky, that means it is a erythema multiforme. If the center is clear, that means it is a erythema marginatum, right? Is that okay up to here?
Yes.
And what is the reason behind this erythema multiforme? It is because of the local inflammatory response of the CD8 cells against these herpes simplex virus and the mycoplasma pneumoniae. Okay, because of the herpes simplex virus and the mycoplasma pneumoniae, the CD8 cells will be activated and they will cause a local skin inflammatory this condition in the skin, right? So that's how the erythema multiforme happens. So it is a pathogen specific CD8 response in the skin. Okay, very important. Then you have the Stephen-Johnson syndrome. Okay, and this is the another syndrome having a positive Nikolsky sign, which means the sludging of the skin with a gentle pressure, right? You will be having a fever, you will be having a billa formations, as you can see. Some kind of a very slight blast will be formed. It is not seen here by much clearly, right? You will be having a sludging of the skin at the dermo-epidermal junction, very important. You will be having a sludging of the skin at the dermo-epidermal junction, right? And you will get the positive Nikolsky with that. You will be having on the biopsy, whenever you do the biopsy of the patient, what you will find is the full thickness epidermal necrosis and the subepidermal bulla formation. Please note that fact. On the biopsy, you will be having a full thickness epidermal necrosis along with the subepidermal bulla formation, right? It generally happens whenever a patient takes any drug and and as a result, a hypersensitivity reaction will be generated for these drugs, and it is a type 4 hypersensitivity reaction. Okay, and you can remember the mnemonic SLAP, Stephen. Okay, S for sulfonamides, L for lamotrigine, okay, A for allopurinol, and P for phenytoin. So these are the 4 drugs which can cause the Stephen-Johnson syndrome. And please note that it is a life-threatening condition. Why? Because you're having a damage at the dermoepidermal junction. All of the epidermis is now gone. As a result, the mucosal protection barrier is now gone. The bacteria can easily cause the infection. And second thing, because of loss of this epidermis, you'll be having a dehydration because of loss of water. So because of a loss of water, because of dehydration, because of skin infection, patient will die because of the Stephen-Johnson syndrome, right? And generally, just give me a second. Generally, you will be having, up to 10 to 30% of surface area involved in case of this Stephen-Johnson syndrome. Okay, but you call it a toxic epidermal necrolysis whenever the skin involved is more than 30% of the body. Okay, whenever you got a more than 30% of the skin involvement, that means it is a toxic epidermal necrolysis. If the less than 30 is present, that means it is a normal Stevens-Johnson syndrome. Okay, yeah.
Yes.
And please note that the mucosal involvement is also very much common in the Steven Johnson syndrome, you will get the positive Nikolsky, you will get a sludging of the skin of the mucosal tracts also, right? Like your lips, like your oral cavity. Okay. Sometimes patient can also get the erythema multiforme as a complication of the Steven Johnson syndrome. So you can get the erythema multiforme both in the HIV, both in the HSV, both in the this mycoplasma as well as in the Steven Johnson syndrome, right? So please remember, whenever you hear the word Nikolsky sign in the question stem, you will always think about these three disorders, right? The scalded skin syndrome, the Steven Johnson syndrome, and the pemphigus vulgaris. This scalded skin syndrome always be a child. Steven Johnson syndrome, a young patient who is on some kind of a drug therapy, and the pemphigus vulgaris will be an old patient, right?
Yeah.
Okay, so that would be everything on this page. Then you have some other miscellaneous skin disorders, and the first one is the acanthosis nigricans, as the name suggests. So you're having acanthosis in this condition, which means a full thickness epidermal expansion, proliferation of the cells. You will get the epidermal hyperplasia, and what you will have is a symmetric hyperpigmented thickening of the skin. As you can see, this is what you get: a symmetric hyperpigmentation of the skin. Thickening of the skin would be there because of the hyperplasia of the epidermis, of course, right? And especially these expansion, these thickenings will be present on the on the skin folds, like the axilla, like the neck. Okay. And these conditions are associated with the insulin resistance, like seen in the diabetes, in the obesity, in the PCOS, right? You will get the condition in the Cushing syndrome also. Okay. Apart from the insulin resistance, this condition will also present in the malignancy of the GI tract, like in the gastric adenocarcinoma, right? And you can also get the skin tag presence on this acanthosis nigricans. Okay, so very hyperpigmented, thickened plaque-like thing you will get on the skin folds, and plus you will also get the skin tags on these areas. So these are the acanthosis nigricans. Any doubt?
No, thank you.
No.
Then you have the actinic keratosis, which is kind of a pre-malignant condition. Okay, it only seen in the patients with a prolonged history of sun exposure, which means this is always going to be a case of an old age patient who has a history of a very prolonged sun exposure, like a farmer could be, it could be a security guard, okay, or it could be any other individual, a labor worker. Okay, they generally have this actinic keratosis because of a prolonged exposure to the sunlight. Okay, it is basically appear as a very unpigmented lesion, but these patients will have a very these lesions, they will have a very sandpaper like rough texture. Okay, if you feel these lesions with your hand, what you will find is a sandpaper like rough texture of these lesions. And please note that these lesions are not hyperpigmented. Okay, they're hyperpigmented lesions. They could be erythematous, they could be slightly brownish, and they could be a unpigmented lesions. Okay, only seen the patients with the chronic UV exposure. And on the biopsy, what you will find is the parakeratosis. Only two conditions where you get the parakeratosis: one is the psoriasis, and second is the actinic keratosis. Okay, and the patient will have a risk of squamous cell carcinoma. Okay, with these actinic keratosis. Okay, and yeah, that would be all. So if you encounter a patient who is having some kind of a plaque or papule, having some this rough sandpaper like texture, old age patient with a history of very prolonged sun exposure, that means you're talking about the actinic keratosis. Then you have the erythema nodosum, okay, which is basically a very painful inflammatory condition, and the inflammation affects the subcutaneous fats, right? And that is known as the paniculitis. Okay, the inflammation of the subcutaneous fat is known as the paniculitis. Okay, this condition mostly appears the anterior shin. You will be having some formation of the nodules over the skin of the shin, and these nodules are very much painful. Okay, this condition is associated. Just give me a second. Yeah, this condition is associated with the sarcoidosis, coccidomycosis, histoplasma, TB, right? And one. Sorry about that. One more disorder from the CVS in which you can get the rhamnodorsum. What was that? I'm forgetting the name. After the endocarditis.
Lofgren syndrome.
Oh, no, not that one. The heart condition in the child, right? After the sore throat, what you will get?
Strep pyogenes?
Yeah, yeah. What this condition called?
Scarlet.
Fever?
Rheumatic
Yeah,
fever.
rheumatic fever. Yeah, rheumatic fever. Sorry about that. I forget the name. So in the rheumatic fever also, if you guys remember, one of the symptom of the rheumatic fever is the presence of these nodules, right? Yeah.
We had subcutaneous nodules over there.
Yes, of course. And these are subcutaneous nodules.
Okay. Okay.
You're having the inflammation of this subcutaneous region, and because of that, some bumps appear on the skin, right?
Yes.
And these are the subcutaneous nodules which are we are talking about, right? So in the leprosy also, in the inflammatory bowel disease, you will get the erythema nodosum, right? And whenever you get the episodes of this erythema nodosum, okay, in case of this inflammatory bowel disease patient like the Crohn's disease or the ulcerative colitis, okay, these are the signs that the patient gonna have a flare uh, of this Crohn's disease or the ulcerative colitis, because you know that these conditions are very much episodic in the nature, right? You will have the flare, then you have the resolution symptoms, then a very months or years without any symptoms, then again patient will be having the diarrheal episodes, right?
Yes.
So just before a diarrheal episode, patient can also get the erythema nodosum, and this will uh, make the patient know that he's going to have the episodes of diarrhea. Okay, so these are kind of flares just before the appearance of this diarrhea thing. Okay, so that's about the erythema nodosum. Okay, you'll be having a paniculitis with the multinuclear giant cells. Of course, whenever you have an inflammation, you can have a multinuclear giant cell. And this condition only affects the mostly affects the lower extremities, especially the shins and anterior shin, right? And please note the risk factors. Any doubt?
No, thank you.
And please note these are painful nodules, not the itchy nodules. Then you have the lichen planus, and these are a very these are very pruritic papules or the plaques over your skin. Okay, and please remember the 6P of the lichen planus. One thing, these lesions are very much pruritic. These lesions are very much purple or sometimes red also, right? These are polygonal. Okay, they could be papules, they could be plaques. Okay, so yeah, these are the 6Ps of the lichen planus. You can also have the mucosal involvement in the lichen planus, and they will form some kind of a whitish striae known as the whitish lines known as the Wickham striae. Okay, you will have the hypergranulosis. Very important. You will be having a hypergranulosis in case of lichen planus on the biopsy of the lesion. Whenever you do the biopsy, you will get the hypergranulosis. It is a very unique thing for the lichen planus. Okay, you will also having the sawtooth infiltration of the lymphocytes at the dermoepidermal junction. And the easy way to remember this condition is that you must know that this condition is also associated with the hepatitis C. Now, because hepatitis C is a viral infection, you will get the lymphocytes, right? And because it is a complication of the lymphocytes, then you do the biopsy, you will get the lymphocytic infiltration. Okay, right?
Yes.
So remember the hepatitis C, remember the lymphocytes, remember the hypergranulosis, right? And remember the infiltration of the lymphocytes in the form of sawtooth appearance, right? Very important. And yeah, so there will be a very highly pruritic rash on the patient's body. Okay. Any doubt on the lichen planus?
No, thank you.
Okay, then you have the pityriasis rosea, okay, which is basically seen after some infection. First of all, you will be having a viral infection, and when the infection is over, then you will get this condition, the rosea. Okay, and so it would be appear as a single. It will appear as a solo patch, okay, which is known as a Herald patch. And after this solo patch, patient will start having multiple patches all over the skin, right? So a single patch will be there, and then the patient will be having these multiple plaques all over the body, and this condition is known as pityriasis rosea. And because it is followed by a viral infection, patient will have a resolution of symptoms after the 6 to 8 weeks. Okay, so it would be a patient who is having a symptoms, and the symptoms will only persist up to the 2 months. If you get a patient who is having some kind of a rash for more than 2 months, then you can easily neglect the option saying pityriasis rosea, right? So very important to know the duration of the symptoms. It is within 6 to 8 weeks only, right? And generally patient will have a history of the viral infection like the diarrhea episode or could be a pneumonia thing, right? And these lesions, they are in the form of Christmas tree appearance, as you can see. See the orientation of these patches, you know, these are like that. If I annotate it, these are like that, right? In this direction they are all running. Yeah,
Okay.
so this is known as a Christmas
Yeah.
tree pattern of the this pityriasis rosea. Okay.
Yeah.
Okay, so yeah, this is all about the pityriasis rosea. A single patch would be there, and after the patch, patient start having these multiple rashes all over the body in the Christmas tree pattern, and they will have a history of any viral infection. And after 2 months, the symptoms will be resolved. Then you have the sunburn, and sunburn is because of the the UVB. Okay, and the UVA can cause the tanning and the photo aging. If you guys remember the lectures from the biochem, we have discussed about the photo aging. Okay, and because this UVA is very remain in the superficial layer of the skin, it can cause the tanning and it can cause a photo aging. While the UVB, it will be deeply absorbed in the skin and it can cause the skin cancer and the sunburn, right?
Yeah.
And what kind of DNA defect you can have with the UV light, with the sun exposure?
XCR.
What is XER?
NER.
What is NER?
Nucleotide excision repair.
Duplicate
Yeah,
excision.
nucleotide excision repair, right? And why this excision repair occur? To correct what kind of repair?
Pyrimidine dimers.
Exactly.
Dimers.
You will be having a formation of pyrimidine dimers, and it is because of UVA or UVB.
B.
Exactly, it is because of the UVB light. Very important. So that would be everything on this page. Any doubt?
No, thank you.
No, thank you.
And then you to know about the burn classification. Okay, so before we go to the classification, first thing you need to know, whenever you have the burn, you instantly have this redness and the blanching lesion over that area, right? So Stefan will ask you why this blanching lesion or why this redness over that area is present. So it is all because of the release of histamine. Okay, as soon as you get the burn, okay, the mast cells will be decannulate and they will release the histamine that can cause the blood vessel dilation. Now, because of the blood vessel dilation, you will get the redness over that area because of increased blood flow. Okay, you will get the blanching type of lesion would be there. Okay, whenever you press on that area, it will become very pale, and whenever you release, it will become very red again. Okay, so this blanching and this redness, it happens very immediate after the this burn occurs, and it is all because of the histamine release. Okay, blisters in the burns, they happens because of a rupture of the blood vessels. Because of a very deep burns, even the blood vessels can get ruptured, and when the blood vessels get ruptured, they will release all this blood and all this serum, right? And as a result, you will get the blister because of that. Okay, it is because of the extravasation of the blood through the gaps between the venules of the endothelial cells, and because of the destruction of the blood vessels itself, right? So it will be a result in the blisters from the collection of the serous fluid between the dermis and the epidermis, right? So please know the causes of the redness, of the blanching, and the cause of the blistering. Any doubt?
No, thank you.
Okay, then let's discuss the burn classification. First, you have the superficial burn, okay, that involves the epidermis only, okay, and because the only epidermis is involved and due to a release of this histamine, you will get the very painful red blanching lesion. Okay, and it can mimic the sunburn also. Okay, just like the sunburn, you will get a very redness, very blanching lesion, and it is a very painful condition because all these nerves are still intact and you're having a damage of the cells, right? Then comes a superficial partial thickness burn, which involves all of the epidermis and a superficial dermis. So epidermis complete and a superficial dermis. Okay, whenever burn reaches to the superficial dermis, it is known as the superficial partial thickness burn. Okay, it will appear as the blisters now. Whenever the dermis is involved, because the blood vessels are present in the dermis, these blood vessels can get ruptured. They can cause a blister formation. Blanching still would be there with the pressure. Okay, swelling would be there, warmth would be there, and this condition is again very much painful. Okay, then you have the deep partial thickness burn. Okay, which includes all of the dermis again, sorry, which includes all of the epidermis and a very deep dermal layer. Okay, so up to the superficial dermis layer you will be having a superficial partial thickness. Up to the deep dermis layer you will be having a this deep partial thickness burn. Okay, blisters will be present. Now the blanching does not present because most of the blood vessels are get ruptured. Okay, blanching won't be there because blanching only there when the blood is still in the capillaries, right, in the blood vessels, right?
Yeah.
If you get the extravasation of the fluid, then you won't get the blanching. Instead you will get the edema, you will get the blister formation, right? And these conditions are painless because deep in the dermis layer your nerves are also present and they will get damaged because of the burn, and when the nerves get damaged they won't send any impulse for the pain, so this condition will be painful. Although you can get the pain whenever you deeply press on this burn, you can get the pain, but not with a milder press or not in the general you won't get the pain. Then you have the full thickness burn. Okay, in the full thickness all of the epidermis as well as dermis will be involved. You will get a white waxy dry appearance. Condition is painless. Okay, and you have the deeper injury burn in which you're having also having the involvement of the muscles as well as the fascia along with the skin. Okay, it would be a white dry layer without any blanching, without any uh, kind of blisters. Okay, and these conditions are again very painless. Okay, so this is a classification of the burn. It would be a superficial burn only, then the superficial partial thickness, deep partial thickness, deep full thickness, and then the deeper injury burn, right? Any doubt on
Yeah.
the classification?
No, thank you.
Now, whenever you have the burn, okay, you're having a loss of the epidermis. And one of the major function of the epidermis is to prevent the heat loss, right?
Yeah.
So because of the burn, patient can have the hypothermia because of loss of heat now, because your epidermis is now damaged, you will be having a loss of heat and that can cause the hypothermia. Now to compensate that, to compensate the loss of heat, the patient's body will try to compensate it by increasing the energy expenditure, okay, by creating a hypermetabolic state. Okay, so patient will be having a hypermetabolic state that will produces the heat for the patient. Okay, another thing is to prevent the patient from the infections because it acts as a barrier. So now the barrier is gone, patient will be having a prone to infection. They will get the wound infection, and mainly because of the pseudomonas and the aureus, and that's why you do not take this flowers in the burn units, right? Because they're very much prone to the infection. And the very important location of the pseudomonas is the water, right?
Yeah.
So that's why the flowers are not allowed in the burn patients unit. Okay. And if you guys remember from GI lectures, we have discussed about the curling ulcers, right?
Yes.
So because of that thing, because of loss of fluid, you will be having a decreased blood supply to the GI tract. You will get the curling ulcers also. So they will present as the very severe type of abdomen pain. Okay, and yeah, because of this loss of fluid, because of the dehydration, patient can also get the hypovolemic shock. So patient can get the high energy expenditure because of hypothermia. Patient can get the loss of fluid, hypovolemic shock. Patient can get the loss of proteins or infection of the wound and the curling ulcers. These are all the uh, the complications of the burns, right?
Yeah.
And they can ask you about this extent of the burn injury. Okay, they will give you a patient having a burn injury to the thigh or to the abdomen, and they will ask you how much body percentage is basically involved in this burn. So please note, for the head, you will be having a 9%, okay, 4.5% anterior, 4.5% posterior, okay. For the thorax, it would be 18%, 9% anterior, 9% posterior. For the abdomen, again 18%, 9% anterior, 9% posterior. For the legs, entire leg, it would be a total of 18% per leg, 9% front in the anterior, and 9% in the back. So for the one leg, 18%, another leg 18%, right? For the thigh, if you divide the 9% into two halves, for the thigh it would be 4.5%, for the leg it would be 4.5%. Similarly, on the back side, 4.5% and 4.5%. For the hand, it is only 9%. So a 4.5% anterior and the 4.5% posterior. Okay.
Yeah.
So step one will give you a patient who is having a burn injury of the hand or the thigh or the abdomen, and they will ask you how much body surface area is involved in the patient, right? So you will give the answer accordingly. Please remember, head 9%, uh, thorax 18%, abdomen 18%, legs 18%, okay, hands 9%, right?
Yeah.
Yes.
Okay, so that would be everything about the burn. Any doubt on this page so far?
No.
No,
No.
thank you.
Okay, so can we wind up here now, guys?
Yeah,
Yes.
okay.
Yeah.
Hi, I had one question.
Yeah, to us.
Yeah. So when we're talking about the hypothermia or we are hypothermic, which is leading us to a hypermetabolic state.
Yeah, it is kind of a, two things are there. One is a wound healing, and second is a hypothermia. To compensate the hypothermia, body need to increase the metabolic demands, right? So that more heat could be produced.
Okay, I understand now. So we're starting off with the hypo, which is leading
Right.
to hypermetabolic
No,
state.
hyperthermia won't occur, but a hypermetabolic state occur.
Yeah, okay, that makes sense.
Okay.
Thank you.
Exactly. Any more doubt? Do ask, please. Any more doubt?
No, thank you.
Okay, so we will wind up here for now. Okay. Thank you so much.
Thank you.
Thank you. And what's the plan for the next few days?
Yeah, I think we should go with the same pace. And whenever I feel like I'm tired, we can take the day off. Okay.
Yes. Agree.
Okay.
Yeah. I think
Yes. Agree.
that would be okay. Okay. No?
Yes.
And if you guys want to change the timings, we can shift the timings into the morning also. If you guys want that, we can shift the timings to the morning also. Okay. You can discuss that amongst us. Okay.
Whatever convenient for you, we can follow.
Okay. So
I
we will
think we
discuss.
can follow.
I like
Yeah.
time.
Does anyone have any problem with the timings?
No.
Any issue?
No.
We can follow same, I think.
Okay. So we will continue for the same. Okay.
Yep.
Okay, thank you.
Thank you. Thank you very much.
Thank you. Thank you so much,
Thank you
everyone.
so much.
Thank you.
Thank
We will meet tomorrow.